And I hope we have a YouTube recording also, Vishal. Please inform the team.
Yes, ma'am.
Ma'am, we are live in 3, 2, 1. We are live now.
Good evening, everyone. Good evening, dear faculties. Good evening, dear audience, and a very warm welcome to you on this beautiful, Thursday evening of 20th of July. And I am really honored to have all faculties and our chairpersons and guests with us. So this ISAR Perfection series is a joint venture between Indian Society of Assisted Reproduction along with an academic group called Perfection, where we deal with one particular topic. We try to do it sometimes twice a month or maybe once a month, depending upon the how busy we all are. And this is Perfection Series Season 6, where we will be discussing everything possible about poor responders in a span of 3 hours from now. So I start with a little introduction that poor responders to ovarian stimulation, this is one of the most challenging problems that IVF specialists face. And as a failed cycle can cause considerable emotional and economical loss to the couple, adequate fertility counseling is essential to address the patient's expectations, especially when there's a poor ovarian response. Now, so many new developments are coming about in this area, and we are very excited because now we know that follicular development is not occurring only in the follicular phase. It occurs in waves, like maybe 3 waves in an ovarian cycle. So unconventional protocols for ovarian stimulations sometimes work in these couples. They have to be chalked out, and these protocols can begin, interestingly, on any day of the menstrual cycle. So ART rules are also being discussed in this webinar, and these ART rules and laws are not there to make us uncomfortable. They are actually there to make our lives more streamlined, because in the beginning, any new regulation can appear tricky, but it always makes life more simple and comfortable at the end of the day. Now, what is important is aging. Aging will impair oocyte competence because insults happen like mitochondrial and cohesiveness dysfunction, shortening of the telomeres. We've studied so many times in the Genetics Perfection series, and the spindle becomes unstable. Specifically, this oocyte aneuploidy has got a U-shaped curve. So the maximum aneuploidies you'll be seeing around menarche and around menopause. And the least sort of aneuploidies happen at the age of around 25. And this is the age where women don't like to settle down at this time. So to carry out this conversation forward, we'll have a galaxy of speakers now speaking. And I will begin with thanking my ISAR president and office bearers. The first person I would like to acknowledge and thank is ISAR President, Dr. Nandita Palshetkar. Nothing to be spoken about, madam. She is a star. She is a very, very prominent leader who has been bestowed fellowship from Royal College of Obstetrics and Gynecology. She is an eminent IVF specialist with almost 3 decades of experience. She is the medical director of Bloom IVF Centers, which are 7 centers all over India. Madam is an alumnus from the prestigious Grant Medical College, Mumbai, and she has specialized in ART from world-famous IVF units of Belgium, Italy, and Copenhagen. Madam has been the pioneer of the latest techniques and technologies in IVF and ICSI, including laser hatching, blastocyst culture, spindle view, oocyte embryo ovarian tissue freezing, IMSI, metabolomics, and so many other things. Apart from that, madam is a fantastic teacher. There are fellowship courses in reproductive medicine in national board that madam heads, and at Lilavati Hospital, Mumbai. Madam has been orator 85 times and delivered more than 900 talks, authored more than 100 chapters and papers, and edited 25 books. Coming to her leadership roles, Madam is the current president of ISAR 2022. She was president Foxy 2019, heading 35,000 gynecologists. She has been president IAGE 1718, head of the steering committee Manyata Project 2019. State level president AMOX 2020 to 2022, city level president MOGS 1617, Foxy representative to FIGO, member of FIGO Committee on Health System Strengthening and Respectful Care, and also the FIGO heading the FIGO project of PPH. Madam is a very key person in the state supervisory board of PCPNDT. That's how she, solves problems for us. The uterus transplant committee, ART and surrogacy bill, midwifery care, and is the recipient of so many awards, including Dr. B.N. Purandare Outstanding Service Award, Dronacharya Award, CSR Award, Femina Superwoman Achiever Award, Bharat Gaurav Award, and she has also received award from the president. Welcome, ma'am. Next slide, please. I also visit this episode of ISAR Perfection is with our Odisha chapter of ISAR, and I'm thrilled to introduce Dr. Sujata Kar, who is the Honorary Secretary General of ISAR, as well as heads Odisha ISAR. She is a practicing gynecological endoscopist and assisted reproduction practitioner for the last 3 decades, with special areas of interest like PCO, proteomics of male infertility, and stem cells in gynecology. She has been a keen academician, recipient of 7 gold medals in MBBS and MD, credited with the first IVF baby of Eastern Odisha, first TESA, frozen embryo laser hatched baby of Orissa. She is the recipient of Pariche Award for Women Achiever in Orissa 2019 at the hands of the Honorary Governor Orissa, Devi Awards for Dynamism and Innovation from CM of Orissa, and Brand Icons Excellence Award 2018 for the Best IVF Center in Eastern India. She has given several publications related to PCO, male fertility in index journals, written several chapters, and has reviewed many international journals. Madam is the Honorary Secretary General of ISAR India and the Executive Committee member of IAGE, PCO Society, and Fertility Preservation Society of India. Next, it's my honor to welcome our dear Dr. Sunita Tendulwalkar, ma'am, who is the Senior Vice President of ISAR.
Monica, we
Yes,
are doing in India, everyone knows us.
Okay.
I don't think academic time we should be putting on introducing. These
Right.
are the academic things, and I will appreciate to keep this academic. Don't introduce me, but
Okay.
honor our chief guest and those who have come. Let's
Yes.
introduce in few lines them, and you can have their blessings, and let's continue. Don't waste my time. Means, my introduction.
Okay, ma'am. So my co-convener, Dr. Randhir Singh has joined. He will be introducing our chief guest and guests of honor. Dr. Randhir, are you there? Please unmute.
Nandita and Sujata are president secretaries you introduced. That's wonderful.
Yes, ma'am. Ma'am, Dr. Nandita just talked to me. She wanted to join and we wanted to...
I saw one Lilavati iPad also. So someone, she is trying her best to join, but that's okay. She will talk when she joins.
Okay, ma'am.
Dr. Monica, Dr. Monica, you can call Nandita ma'am. Meanwhile, I'll introduce our chief guest, Dr.
Yes,
PC
please.
Mahapatra sir.
Please.
So,
Yes.
I'm honored to introduce Dr. PC Mahapatra sir. I think, as Sunita ma'am told, he's a star of the Foxy India, and he was a president between 2011. Then he was a Foxy representative, SAFOC 14-15. Then with the Vibhushan Award, Foxy and ICOG 21, Foxy Lifetime Achievement Award 23 this year. ISAR Lifetime Achievement Award in 23 we gave in the Bhopal. I was honored to give him from my platform from Bhopal. Then he's a soul as a teacher, founder is a Pachi Institute of Mother and Childhood, chairman, Prachi Education Foundation, Life Mission Born to Serve Living Others, Working Till Last Breath, Teaching is my passion, to be a man rather than a great man. And he, fantastic, everybody, we were there. Sunita ma'am, he delivered a fantastic oration in the Kanpur, defining a mother. So, PC sir, welcome to this webinar.
I think sir might join. I have already informed his assistant. We can proceed to introduce guests of honor, please.
So I'll introduce again the IFS Secretary, Madam Professor Sureen Ghumman Sindhu ma'am. She has got a 32-year of clinical experience as a faculty medical college in UCMS, GTVH and other colleges. She has authored many books, more than 10, many publications, around 85, program directors, executive editor, Fertility and Science Journal, peer reviewer of the Journal System Biology and Reproductive Medicine, Journal of Obs and Gynae of India, Journal of Indian Medical Association, position in the Academy Society, Secretary General IFS 22-24, Treasurer she was last year, then Chairperson in Fertility Committee in AOGD, Chairperson Reproductive Endocrinology AOGD 21-23, past editor of Obstetric Gynae Daily AOGD, numerous awards including the Foxy North Yuva Award, Distinguished Service Award IMA 2015, then Satyapal IUG Award and IMA Summit Icon of the Year IVF Award in February 19. Sureen madam, welcome to this webinar.
Thank
Welcome,
you so much. Thank you, Randhir, Monica, and Isar, and Dr. Sunita. Thank you.
Thank you. Thank you.
It's a
ma'am.
pleasure being on board.
Yeah, thank you, ma'am.
Thank you.
Then from my MP, the Jyoti Bindal ma'am, she has been the teacher of our teachers. Now her students are now teachers and HODs. At present, she is a vice chancellor. She at Window University Indore. Then major achievement, she has got J.G. Jolly Oration Award in 21 by National Academy of Medical Sciences, Foxy Shiromani Award 2020, President Association of Madhya Pradesh Gynae Society, Strategic Advisor and Member Executive Committee BTA UK, member of COVID Technical Advisory Committee, because Indore was a very, very bad shape in last COVID. So we know how important her role was in Indore eradicating the COVID. Member State PCPNAD Committee, member District Gwalior PCPNAD Committee, and she has got all the medical colleges, starting from Gwalior, Indore. She has been at HOD, Dean and everything, and ex-Dean, ex-member core in National Human Rights and Commission. She's a very, very good professor, and as personal touch, she's a great soul to helping each other. Jyoti Bindal madam, please welcome. You are here.
Welcome, ma'am. So,
Thank you so much. I think we'll wait
Hi,
for.
Jyoti madam. Hi, Jyoti madam.
Good to see you, Sunita. And once
Yes, we met on Pravas series and now on ISAR platform. Wonderful to see you.
madam, can we have some few words from Dr. Jyoti Bindal and Dr. Sureen Ghumman before we start the program? Can you please?
we don't have to wait for the chief guest and other guests. Shall
No.
we?
Yes, ma'am, please, please. We can start.
So I'm so thankful to Sunita and to Dr. Randhir and Monica for giving me this wonderful opportunity to be a part of this academic series. And what a beautiful concept of topic, poor responders. You know, there are two types of gynecologists, as I say. One who are specifically working in ART, who are IVF specialists, and the others who are general OBGYN specialists, consultants. And poor responders are the people who come to these general consultants, because there's a very big tendency among gynecologists not to refer to the specialist, and that is something which needs to be somewhere, has to be put in the training, that we all must know when to refer, where to refer, and how early to refer. So, of course, as our esteemed speakers will be speaking today about the causes of poor responders, the social causes, maternal age, disturbed hormonal balance, diminished ovarian reserve, and various other causes. So I'm not going to be going in those depths, but I would like to just add a word of caution, is that poor responders should not be permitted to remain poor responders for a very long time. We should not let the treatment pull on and on Especially, this is a word of caution for the general gynecologists, and sooner you refer to the IVF specialist, better it is for the patient. With these words, I would like to congratulate Dr. Sunita. The more I know of her academic brilliance, as I was telling her the other day, the more bigger fan I have become, you know. So it's a pleasure to be on the same platform as all of you. And once again, all the best for your mission which you have undertaken. But more important, all the best for your academic career, which is already on the top. Thank you so much.
Thank you so
So-
much for blessing our program, ma'am. It's very encouraging to hear you on this platform. Very encouraging. Thank you so much, ma'am. Dr. Surveen, we would like to have a few words from you, please.
Yeah, thank you, Monica. I think you have always arranged quality programs, and I think the topic chosen today is one of the biggest dilemmas an IVF specialist faces. If we can solve this dilemma, I think we would be on the top. So a very relevant topic, something we face every day, and something where debates never end. New things coming up in huge amounts, like Dr. Sunita would know, ovarian rejuvenation. She is the president of the society. And that is one big thing coming up in a big way. If we manage to crack that, I think we would manage to crack a poor responder. But I'm not going into a very long this thing on poor responders, because you all are going to talk on poor responders. Thank you for having me here, and thank you Issa, Nandita, as well as Sujata, Monica, Randhir, and dear Dr. Sunita. I wish you all the best. I hope that you achieve success in every endeavor, not just the current one, but in every endeavor so far. Thank you.
Thank you so much, Dr. Surveen. That was
Thank you, Survin, for your kind words. Thank you.
You
Yep.
are one of the warmest persons and one of the most academic persons I know of.
Thank you, dear.
Thank you so much, Dr. Surveen, for being with us. IFS has been such a big support, and I think IFS and ISAR make a formidable team, better than any team in the world.
And
So-
actually, we are doing a lot of programs together, and we are doing them very well. We make a very good team.
Yes, we do. So taking this program forward, I introduce my program coordinators, Dr. Shabana Sultan, who is professor in the Department of OBGY GMC Bhopal, and Dr. Purnima Tiwari. Dr. Purnima Tiwari is a brilliant alumnus from MAMC and Lady Harding Medical College. She is a gynecologist practicing in Bhopal, and she has done her ART fellowship from AIIMS Nagpur. Welcome, Dr. Purnima. And I would invite you to please introduce our first session chairpersons, please.
Yes. So I would like to invite Dr. Modhu Charan Patnaik, sir, for chairing our first session. Sir is an alumni of All India Institute of Medical Sciences, New Delhi, and sir has also worked at Maulana Azad Medical College and senior house officer at Greenwich Hospital, London, trainee fellow of Royal College of Obstetrics and Gynecology, London, European diploma in hysteroscopy and laparoscopy. Sir has visited as observer and trainee in IVF center and laparoscopic centers around the globe at Paris, San Francisco, Washington, New York, Singapore, and so many countries. Sir presently is director of Shanti Memorial Hospital and IVF Center, Rourkela, Odisha, and is founder of First Test Tube Baby Center of Odisha, credit of first IVF and ICSI baby in Odisha since 1999, and has presented multiple scientific papers and delivered orations in national and international congresses. Sir has membership of so many academic organizations and has been felicitated by IMA, Rotary International, and Government of Odisha for his path-breaking dedication for serving to mankind and women health and undying support to the COVID-19 patient of grossly affected Sundargarh district through Shanti COVID Hospital. I welcome you, sir, on this platform. Thank you for joining us.
Thank you.
I would like to invite our second chairperson, Dr. Bharti Mishra ma'am. Ma'am is Professor, Department of Obs and Gynae, MKCG Medical College, Berhampur, Odisha. And ma'am has been past president of POGS, ex-HOD of the same department in the same medical college, and life member of FOXI, ISOPAB, IMS, IAG, and PCOS. Ma'am has been examiner of PG and UG students examination and has publication in national and international journals and contributed chapters in books. She is recipient of Wonder Foxin Award 2020, Swam Siddha Award, and also recipient of Teacher Par Excellence by Prachi Foundation. Ma'am has delivered oration in ISOPAB IMA Odisha, IMA BOGS Bhubaneswar, and closely associated with General College, Rotary Club, Army Campus, Marwadi Mahila Samiti, and so many organizations. Ma'am has passion in teaching, plantation, and providing high-tech treatment to the underprivileged. I welcome you, ma'am, Dr. Bharti Mishra ma'am. Thank you for joining us. So I would hand over the session to the Monu Patnaik sir for introduction of our speaker.
So,
Monu, allow me to share the screen, please. The
Yes.
organizer.
just if you want, Sunita.
No introduction. You know what? Let's be our academic body. Monu, I am your great friend and great friend of Randhir and Monica. Is our senior vice president, and let's go for. Allow me to share the screen.
Please go ahead.
You can have a concluding remarks, Monu.
Oh, fine, thank you.
So first of all, thank you so much. Amazing job done by team Bhopal, Randhir, Monica. Any responsibility you give it to them, they will do the perfection job. I think Isar has done a wonderful job of giving them this. And Namaste, Vanakkam, Sat Sri Akal, and Namaskara, because they always have a national and a global viewership. Whenever I talk about stem cells, I always like to dedicate my talk to none other than my mom, whom I lost on 21st February 2021. But stem cell are the reason why I got 6 years of her life, number one. And she is the reason why I entered in a stem cells. Those who are close to me, they know the story. And she is, to save her life in 2015, I entered in stem cells for kidney diseases. And when you have the facility of developing the stem cells in the lab, you start wondering what are the other potential now where I can use it. And stem cells have given 6 years of life of my mom to me, and that's why I'm grateful to you. Advances in science, friends, are always for the betterment of a human being. And in science, what is important is to modify and change one's idea as science advances. No longer I can think of doing, even in the antenatal care, what I used to do in my residency near 3.5 decades ago. The ideas have changed, science have progressed, our understanding of the subject has increased, and naturally, the health of a woman is absolutely at grade. Now, will stem cell revolutionize the ART treatment? Whether today I have been told only to talk about ovarian regeneration, so I'll focus only on that. So when we talk about stem cells, what are these stem cells? The stem cells in our body is made up of 200 different types of cells. Muscle cell, nerve cell, skin cell, osteoblast. Every cell is arrived from stem cell. They all cells, they once become specialized, then it becomes irreversible. So the process of specialization of this, so stem cell can go into neuron cell, can go into the muscle cell. Once it enter into muscle cell, it is irreversible. But otherwise, stem cells replicate themselves and make many more cells. So unspecialized cells, which are capable of renewing themselves through the cell division, sometimes after a long period of inactivity. This is very important. They may be inactive for long and then they suddenly can start working, or under certain physiological or experimental condition, we can induce them to make into certain organs or tissues.
those who don't know, I must tell them, even they have produced the pinna. The first organ they produced was a trachea, where esophageotracheal fistula, they wanted to implant this. So this is very, very important that stem cells can produce any organ we want them to. And that's why one can culture in the lab even the hepatocytes. And I feel that a decade down, organ transplant or joint replacements may become a history with the stem cells. In infertility, when we talk about stem cell, it is in the ovarian regeneration, endometrial regeneration, or male factor infertility. Let us concentrate today on a decreased ovarian reserve patients. 10% of the women undergoing, our own Padmarekha Jirge has published this in 2016, though I think last 7-8 years, if we really consider, the incidence has gone to 15 to 18%. And pregnancy rate remains low despite of a plethora of intervention in these poor responder patients. And they also have poor egg quality, and hence they have a miscarriage chances. As of now, this issue, whether the mammalian females possess a population of renewable germinal stem cells, remain unsettled, though promising results were seen. The topic of regeneration of the ovary, it is complex, and agreement on a definitive approach to verify the process of ovarian rescue or repotentiation, you can say, is quite elusive. Now, when we talk about, if you see, as early as 2005, the Johnson & Johnson group, they found expression of germinal markers in a bone marrow derived stem cells, and they have done on the mice the study, bone marrow and peripheral blood transplantation, and they found that they could do the recovery of the oocyte in the mice which were sterilized with the chemotherapy. And that's where the promising results in the mammal, we started thinking about, can it implemented even in human being? And after that, for a decade, huge publication from 2006 to 2015. Why I'm saying decade only? Because it is in 2015 August, I decided to enter in stem cell, and 2015 December, the first stem cell therapy happened in my place, that is of my mom. While in 2016 and 17, since we have the facility about developing or separating the bone marrow derived stem cells, we started exploring it into ovarian regeneration. And then these 10 years, we found many publications which tells us that probably autologous ovarian stem cells, we can think about making it. And many independent groups have shown the ability of these autologous stem cells to differentiate into primordial germ cells, which may form the functional haploid gamete. So by the time I entered, many scientists have established again and again that the stem cell may be a current or a future challenge for poor responders. And there are groups who said that there is a considerable evidence that ovarian stem cells can be stimulated and can be formed, and these germ cells will help us to produce the haploid gametes. Again, these are the several publications in 2015 also, bone marrow derived stem cells, ability to colonize and folliculogenesis has been seen. If you go on a clinicaltrials.government site, you will find so many people have registered. So if you see, all these are like a trials. It means it is still not established. And even in India, ICMR has not given it a therapeutic approach purpose. Only 30 conditions are given in the country And mainly they are the bone marrow, the blood cancers, hematological condition, where it can be used as a therapy, while in rest of the condition, it is still under research. Though we are trying to work with central government to give more opportunities to more ART consultants who are ready to work in this field, and it should be given a blanket permission for a therapy. So when we talk about stem cells, we need to harness the stem cells. So how do we mobilize these stem cells from a bone marrow? So this is my stem cell center. The thing has to come in your mind that we can take the bone marrow completely from a posterior iliac bone. Posterior iliac bone, very easily you can go into the tuberosity and you can aspirate. In the beginning, when we started, we used to aspirate 100 cc because as such, we used to read and improve our understanding. And what over the period we found is, if we can take out more than 100 cc, 150 cc, 200 cc, then we can work on more. So if I can take out in a young lady of 30 with premature ovarian failure, 200 cc per cubic ml, count of the stem cell may go better and one can think about. Initially, we had this computerized, digitalized, non-touch technology, but now we know many other processes by which we do the stem cell separation. So when you have this facility, the thinking what happens is, can we take these stem cells and can we inject them into the ovary? Can we think about injecting? Now, when we talk about injecting, where to inject was also a question. And then it is not in this. This is animation, which is wrong. We inject in a subcortical region. If you read now embryology, you will understand that these primordial follicles, which are native, nascent, they are more in a subcortical area. And now we develop the technology by which we go all around in a subcortical area and we work out on. So when we started doing in 2016 and 17, we had India's first baby on 16th April 2018. Believe me, we were waiting for her to deliver. Our all publication was ready. And on 17th April itself, we submitted and we received a mail from Human Reproductive Sciences asking for a review article. I need to thank the Human Reproductive Science Journal, because by that we read, when you want to write a review article, you need to read a lot, and we realize the inclusion criteria till 2018 for everyone was age 40. Ours was only the age 45. Believe me, friends, it's very difficult to do something world record. It's not that India don't have genius, but we don't have enough funds for the research. We have a good scientist also in a stem cell, but unfortunately, they don't have patients. Clinicians have patients, but they don't have much knowledge, and that's where we lag in the world. Now, if you see over the period, we have been cited in hundreds of publications and articles on stem cell therapy, and our citations comes in. So these autologous bone marrow derived stem cells, there are various ways we can put. This Sanket's needle helped me to prove myself, but now no more we do with these methods. We have designed our own needles also. And we know now we have standardized our technology. We have also designed like this, the grasper and putting this. But this grasper cannot open more than 10 mm, and then we cannot hold the entire ovary. Now, what is important is we designed our own specialized needles by which they are sturdy enough to go into the ovary. We take from the cortex, the upper pole to lower pole, and in vertical direction, at least in 4 and 5 vertical planes, we inject the stem cells. The thing is, if you see the publication, the two dilemmas, or I should say unsolved puzzles, how to inject, whether laparoscopically or transvaginal sonography, because every ART consultant is so used to it. The thing is, all the publication, including Carlos, we all know he has a huge work in stem cell. They were doing transvaginal sonography. Friends, when you sit on transvaginal sonography with these atrophic ovaries, these are not stimulated ovaries which are lying in the pouch of Douglas. They are the atrophic ovaries. And what we realize is it is very difficult to fix those. They may be up. They are so many bowel loops come in the way. You may not know you are entirely entering into. So only in 10 to 15% of the cases, I could do in a transvaginal sonography. My 85 to 90% of the cases, I still do laparoscopically where I know precise. So how to insert was one dilemma. Second, we never knew how long they will work for us or when the action will start. So in 6 to 8 weeks, we used to call the patient, we used to see it, how many times we need to repeat this stem cell, all is still unsolved puzzles. So what I used to do is I used to take every patient into IVF and I used to stimulate and take out the eggs which I got in. But unfortunately, in my 20 cases of pilot study, 35% did not conceive with IVF. Now it is expensive therapy to do stem cell followed by IVF. So those who did not conceive, we just asked them to keep the hopes on and try with the natural method. What happened with that was one patient conceived after 18 months and another patient conceived after 22 months. And we realized that the stem cells can work for a long. We did this publication because we wanted whole world to do the publication to improve our understanding about the stem cells and understanding of stem cells for ovarian regeneration. And by now, I have many patients whom I gave a pregnancy, and after 2 years, they are coming with spontaneous pregnancy. It's not that we have done when the AMH was 1.2 and 1.3. When the AMH was 0.01 to 0.05 also, these are the patients who are conceiving now naturally. Tells us the stem cell may work for a longer period of time. So stem cell may pave the way to minimize the need for an egg donation. Friends, challenges are what makes life interesting, and overcoming them makes it meaningful. With our further experience, we kept on, as I told you, 20 cases studies. We wanted to see the safety and efficacy, and we found that they are safe. The only complication is it may not work. And that's where we were happy. As I told you, we are still dark. We don't know when the effect will start and how long the effect will live. And that's where our first 2 cases of spontaneous conception, India's first 2 spontaneous conception after autologous, we published in our own Jogi journal because we felt that this will help those who are doing to make them understand how long they will keep on working. Now, few lines on platelet-rich plasma, because I know many people are doing intra-ovarian platelet-rich plasma instillation. We all know the PRP has ability to do the tissue repair. They cause angiogenesis. They induce the all important interleukins and VEGF and all those factors, and they have been found to stimulate intra-ovarian stem cells as well, who will in turn generate and can produce the oocyte. So there are promising results. If I go back and show you my publication, every time when we did it, we always combined. It is a combined use of, this is from 2017 paper, also our first patient, we always combined bone marrow with PRP. Though we never did PRP alone, because this PRP has an ability to stimulate even these bone marrow derived stem cells which you are injecting. And that was our purpose, though PRP can stimulate intra-ovarian stem cells also. And that's the reason people are doing and we are getting. Even I'm doing certain selective cases But we are very strict with our selection criteria, because if you don't remain strict with your selection criteria, you will not get good result. First, most important selection criteria should be, you should be doing a genetic study of this patient. In genetic study, if it is a Fragile X syndrome or a Turner-Mosaic, because of which they have a premature ovarian failure, whatever you do, stem cells or PRP, it will not work. Secondly, all the cases of endometriosis, presence of endometrioma or previous operated endometriosis, and now it is a stage 3, stage 4 endometriosis. I don't do stem cells yet with them, because I told you in my series, the only complication is it may not work. I do believe that when we do the in endometriosis, any handling, we may land up in ovarian abscesses. And I don't want ovarian abscesses. And that's why presence of endometrioma or endometriosis is contraindicated. Third is tuberculosis. I don't do on those patients. So these are our exclusion criteria. Then autologous, this, if you see in 2018 and 19, there were people who studied, and their cases, though they are small, 4 cases study, they have also raised certain concern against the background of these PRP is, if ovarian stem cells are indeed present, what is the risk of activated PRP triggering tumorigenic or malignant transformation? And this worries me a lot. Autologous bone marrow derived are now tested from 2004. We are in 2023. So near 19-20 years, they are working on it, while PRP is in last 5 to 7 years. Though as of now, they have not found any complication. I always worry 15 years down the line, if this patient comes with the ovarian malignancy and she makes me responsible for inducing it, I'm absolutely will be shocked. So we don't know, frankly speaking, and we should be very cautious, and we should be telling our patient all those probable side effects now and future, and then only you should be taking, because your safety comes first. And this is another by the Scott Seeley's group, who have taken 4 patients. Why I like to show his article, because age group he has included was 42. And in all the patients, he got at least 1 blastocyst formation. So there are many. We all have to understand that every lady has the right to have her own genetic baby, and we should try all the possible way without causing harm to herself. Instead of egg donation or adoption, if she is very adamant, this is the last patient I'll take, my always first advice is egg donation, because it has a more success rate and proven success rate. Time interval to the pregnancy will be shorter. Now with the ART bank coming under the ART bill, I feel we are going to be in a trouble, and that's where stem cell may take up its own position. So friends, if you don't challenge yourself, you will never realize what you can become. Don't forget the ethical concern. Develop your own stem cell committee, ethical committee, and that ethical committee should be tied up with the central ICMR that is called NAC-SCRT. We have in 2018, in recent our stem cell meeting in Delhi, where all faculty, we came together, they were congratulating me having ethical committee approval, because according to them, even AIMS don't have their ethical committee of stem cell yet approved by ICMR. We don't know the reason, but it is not. The ICMR work very slowly. And that's where I went with the central government, with the DCGI, asking them to come do the inspection, see what we are doing, and help us to work. And I have DCGI permission to do use of autologous bone marrow derived stem cells into the female infertility. And then I took a FDA approval also. I believe that stem cells have given me my mom for 6 years, and that's where I need to give stem cells something back. And we just launched last month the Society of Ovarian Regeneration. Friends, this is the first of its kind in the world that India has established the Society of Ovarian Regeneration. There is a Society of Regenerative Medicine in India, even with the ASRM and so many independent groups. I myself is a trustee in Indian Society of Stem Cells, but I felt if Indian Society of the Stem Cells or the Regenerative Medicine is doing the work in all the fields, but if I want to take the gynecologists like-minded, we do the research, we take the permission from the government with maybe 50, 100 gynecologists, I need to form certain society where the norms will come in, everyone will follow with that, and we can come out with the concrete data. Either it works or it doesn't work. And it's not only the stem cells or PRP, there may be many more new components over the future we can develop and we can regenerate and we can think about. We can think about antioxidants, injectable. Can I give them? Will it help me to stimulate intraovarian stem cell? There is so much unexplored science yet, and unless we form the organization, it will not come. So on 27th May 2023 in Mumbai, we formed the organization after laying down certain with so much of extensive work and 6 months banging our head on constitution. And now I got from Charity Commission the PAN card and the bank accounts and all. And so once another 10 days, let my election get over and we will start working on this Society of Ovarian Regeneration. So those who are listening, they want to join this society, want to join in the academic work, please write to us and we will help them. Always think when you climb many hills, never think you are on the top of the hill, because next day then you will have a downfall. Remain grounded, remain humble, and try to see many more unexplored fields, like many more hills to climb. One life is not enough to do everything. What is very important is choosing the path less chosen. That makes all the difference. Try to have a daring to walk on the path and work on this field. Remember one thing, science is not only compatible with spirituality, it is a profound source of spirituality. Don't think you are doing everything. Think that God is helping you to do. He's the creator, he's the performer, he's using you as a media. The day you will accept this, and the day you will invite more and more God to help you, you will realize you are started getting miracles, not only with one patient, but many more patients. Friends, I'm going for a Foxy presidential candidate. I need blessings of you all. On 1st August, 10 a.m., the voting line will start. Have a coffee. Don't keep much morning surgeries. Wait for the Foxy SMS. You will get the link. Everyone will have a separate link. It cannot be transferred. Click the link. You will receive the OTP. Put it. Your ballot paper will be open. Find the name Sunita Tandulwadkar and you just click that name and you will vote for me. Thank you so much. Thank you. You are muted. Sorry.
Dr. Monu, you're muted, sir.
Now, can you hear me now?
Yes, sir.
Yeah, that's wonderful. And Sunita is always like that. Where there is a will, there is a way. And the hope is what we live on. Ovarian rejuvenation relates to that with the advancement of research and the medicines. You are coming up with a wonderful option to carry on this hope for the woman and contributing to motherhood. And Sunita, you have done perfectly then, and you are the real master in doing this, and you have shown the way to everybody of us. Thank you. I'm so delighted and be happy and fortunate to chair this your session, and I'm very, very happy that you have come up with really wonderful things.
Thank you. Thank you.
Thank you so much, ma'am. We have listened to madam. We have seen her tours. We have seen her spirituality. But today the lecture, I've listened so many talks from madam, but today her lecture had that very profound, something profound, very deep emotion. And madam, you are on the right track. and God is always having his hand on your head.
Thank you. Thank you.
Purnima, we will keep next intros very short, please.
Yes,
Okay?
ma'am.
At
Yes.
the second session, yes. Second session to be started.
Yes. So for chairing our second session, I would like to invite Dr. Leelavati Guru ma'am. Ma'am is consultant Ops and Gynae and has been WHO fellow in ART and infertility and has a special interest in infertility and high risk pregnancy. I welcome you, ma'am, on this platform. Dr. Leelavati Guru ma'am.
Thank you. Thank you.
Thank you for joining us, ma'am. Ma'am, I would like to hand over the session to you for introduction of our next speaker, Dr. Manish Bankar, sir.
Thank you very much, Purnima. And good evening, everybody. I feel honored to introduce Dr. Manish Bankar. He has a lot of achievements to his credit. And he is one of the founder member for this ESAR Perfection webinar series. And we are all proud of you, sir, as a member board of director Poseidon Group. Dr. Manish Bankar is the director, Bankar IVF and Women's Hospital, awarded the BC Roy Award by the Medical Council of India for the year 2017, past president ESAR 2012-2014, regional representative, International Committee for Monitoring ART, senior associate editor, Journal of Human Reproductive Science, member board of directors Poseidon Group, member surveillance editorial board IFFS 2011, 14, 17 and 20. Member board of directors Pacific Rim Society of Reproductive Medicine. Founder member ASPIRE, member draft committee for ART Bill of India. And sir is enlighten us, sir is enlightened, we'll talk about optimal management of the poor responder. Over to you, sir.
Thank you very much. Indeed a pleasure to be called to speak at this ESAR webinar series. And it is good that I am following up with Dr. Sunita Tendulkar, who spoke so nicely on the issue of ovarian rejuvenation and stem cells. So I will be focusing on what we can do as the other traditional options before we need to resort to this ovarian rejuvenation in any kind. So poor ovarian reserve or response has a lot of issues associated with it. And it essentially begins with how do you define that a woman has ovarian insufficiency or ovarian deficiency or poor ovarian reserve. Because reproductive aging is more or less a continuous process right from birth till menopause. And anywhere between 9 to 24% of women have some or the other form of ovarian reserve. But if we look at patients undergoing IVF, nearly 10% of women would have this kind of poor response. If you look at the data from various international registries, nearly 14% of the cycles get cancelled after they are being started, and more than 50% of this is because of a poor response. So ovarian reserve essentially means what is the functional potential of the ovary, and it should reflect both the quantity and the quality of oocytes that are present in that ovary. So if you look at the entire cycle of the formation of the oocyte, right from primordial follicle to the corpus luteum, it is this area between the pre-antral antral follicle stage that forms the functional ovarian reserve, because this is the part from which the mature follicle is going to develop. So under normal circumstances, the FSH stimulates the ovary, and when the ovary is normoresponsive, even a small amount of FSH would lead to good ovarian response. But as the cohort or the reserve becomes smaller and smaller, increasing amounts of FSH are required to stimulate that ovary. And in spite of this, the ovary then produces fewer and fewer follicles. Now, this will be reflected many a times in earlier selection of the dominant follicle. So you have asynchronous growth and there is advanced follicular growth. So cycle becomes shorter. And because of this, the baseline estradiol levels keep on increasing. So even before the FSH starts to rise, early selection of dominant follicle and early baseline E2 levels are the earliest reflection that the ovarian reserve is possibly starting to fall. Now, in spite of the problem being so common, there is still no clarity in definition. And this paper from 2011 shows that there are nearly 41 different definitions to this. There are 47 RCTs, 41 definitions, and each of this looks at poor ovarian response from various aspects, from age to AFC to FSH to follicles to estradiol levels to good quality embryos to the FSH dose required. So this is a very incongruous group. And the first attempt to define poor ovarian reserve was by Eschrey, and the Bologna consensus was published in 2011. And this defined that a woman should satisfy two of the following three features to be put in the category of POR. One is that she should either be older than 40 or should have any other risk factor, or should have had a previous cycle with less than 3 oocytes with a conventional stimulation, or should have an abnormal ovarian reserve test in the form of AFC or AMH. But this was very much criticized because there is a very different variety of population here. Even the cutoff values for AFC and AMH are range bound. It is 5 to 7 follicles or 0.5 to 1.1. And there was no mention about the quality of oocytes versus quantity. And this was not subjected to large-scale validation. So the second attempt to define this was by the Poseidon group in 2016. And the endpoint that this looked at was the number of oocytes that you would require to have one euploid embryo. So this was not on the number of oocytes alone, but how many oocytes would you need to produce one euploid embryo? And as the age of the woman kept on increasing, you would need higher and higher number of oocytes to achieve that euploid embryo, because this is the ultimate aim of the IVF treatment. So based on this, women are classified into 4 groups, 1, 2, 3, and 4. 1 and 3 are the younger women, 2 and 4 are the older women. 1 and 2 are young and old patients with reasonably good ovarian reserve, but their response is suboptimal. 3 and 4 are young and old women who have a poor reserve to begin with. So these were the 4 groups in which the Poseidon group classified them. There is also another thought process that we should generally not classify the response as poor, because it could be stigmatizing and traumatizing. And Eschrey recommends that you should use the terminology low ovarian reserve instead of poor ovarian reserve. Now, what are the reasons behind such poor ovarian reserve? Now, this could be one of the 3 following options. One, there could be reduced number of FSH sensitive follicles in the ovary. This means that the reserve is actually diminished. There are fewer and fewer antral follicles. Or there could be suboptimal exposure to gonadotrophin, which means that the patient was inadvertently stimulated with an inadequate dose, or she could have a very high BMI where the traditional doses are not sufficient, or there could be an issue with the FSH receptor, whereby the follicles are less sensitive to gonadotrophins and hence need a higher stimulation. So the reasons behind this low ovarian response could be one of the 3. Now, for all this, the AMH and the antral follicle count are the 2 most reliable predictors of the ovarian reserve. But both of these test the quantity and not the quality. As far as the quality, which means the percentage of euploid or aneuploid embryos that you would get, age is the best predictor. So both AMH and AFC should be seen in conjunction with the age, because your ultimate aim is to have a euploid embryo. So let us look at the reasons behind this. So one of the reasons for low response is the low starting dose. And nearly 10% of women who are the so-called normal responders based on the examination, AFC, AMH, or age, still require a higher than expected dose to promote adequate follicular development. And these are the 10% of women who are likely to benefit if you alter the dose. There could also be many genetic factors which could be responsible for the poor result. And in an ideal world, or maybe in the next couple of years, you could have pharmacogenomic algorithms. These are our treatment algorithms based on the patient's gene profile, which would tell us which patient is likely to need a higher dose in spite of a normal ovarian reserve, so that you could have personalized drug therapies. But this is yet not available to make it in a cost-effective fashion. And the third issue is that of genetic polymorphism, the FSH receptor polymorphism. And the certain receptors which are implicated in this are RS6166 or the serine 680 variants. And if the patient has such receptor variants, she would require a higher dose of stimulation. This would mean that maybe if we could test all the patients before starting the stimulation, you could avoid this. However, studies have yet not proven the utility of such pharmacogenomic testing on a routine scale to make it cost effective. So this is essentially still in the era of research. So how do you measure now that the response is adequate or not? And there are two indices which one can look at. One is the follicle output rate, which means from the antral follicles, the number of antral follicles that you see at the beginning of ovarian stimulation, how many pre-ovulatory follicles do you get? And second is the FOI, which is from the number of antral follicles that you see in, how many oocytes do you get? So let us assume here, number one, when the patient has 15 antral follicles, and if you have 15 oocytes or 15 pre-ovulatory follicles, this is adequate response. Second is a patient who has 5 follicles and you get 5 eggs. This is still normal response, though the number of eggs is low. For that patient, this is adequate. But if the patient who has 10 follicles produces 5 eggs, or the patient who has 4 follicles produces only 1 egg, these are the patients where the response is lower than 50% of what one would have expected. And these are the patients who are likely to benefit from treatment. So this brings us to the main question as to how do we treat these patients? What can we do pre-treatment? What can we do during the treatment cycle in terms of protocols, gonadotrophin, starting dose, etc.? Are there alternative therapies? And what about the adjuvants and newer treatment options? So you can see from this table, so many recommendations have been given for poor responders. And this actually tells us that we have not yet been able to find the right answer as to how do you treat these women. So people have used the long agonists, the short antagonists, various gonadotrophins, doses, natural cycle, mild stimulations, etc., etc. And a host of adjuvants from DHEA, testosterones, recombinant LH, growth hormone, etc., which have been tried. But let us look at the evidence. Now, which gonadotrophin should you use when you want to treat a low or a poor responder? Now, studies have shown that using a recombinant formulation is better, primarily because it is a more consistent molecule. With the urinary products, because of the assays by which these are measured, there is a large coefficient of variation and a large variation in the actual strength of the ampule, and hence the response may not be consistent. So giving a recombinant formulation makes the response consistent because their potency is more consistent. The second is the addition of recombinant LH, or you could use gonadotrophins which have a combination of both FSH and LH activity. People have also tried to use a combination of FSH and HMG, which in an antagonist protocol has been compared with the addition of FSH to LH. So what do we do in terms of the protocol? Now, these are the patients where a stimulated cycle is preferred over a natural cycle, because in a patient with a poor prognosis, natural cycle cancellation rates would be still significantly higher. If you compare the agonist versus antagonist, there is hardly any difference. This is an old study which shows a non-significant increase in number of oocytes in the agonist cycle. And this was primarily because of better synchronization. But now you have means of synchronization even in an antagonist cycle. So the advantage that the agonist had because of follicular synchronization can more or less be achieved in an antagonist cycle also. Now, what about increasing the starting dose? So this is a beautiful study which shows the response based on the starting dose from 150 units to 300 units. And you can see that the number of follicles increases in a linear fashion as the starting dose is increased by every increment of 25 international units. So this regression analysis shows that an increase of 50 IU in the initial dose would add 1 extra oocyte to the stimulation. And this is seen up to a dose of 300 international units. So increasing the starting dose does seem to help. But the category 3 and 4, which have an inherent low ovarian reserve and hence have very low recruitable follicles, gonadotrophins will
Hello, Banker sir. I think sir has got disconnected.
Yeah.
We will wait.
Dr. Manish Banker's screen has frozen, or I am?
No, madam, the sir has temporarily got disconnected, I think. His screen is frozen. I'll call sir.
Yes, sir.
Purnima, you're calling?
Yes, ma'am, I call, sir. Is just logging it again.
Okay. Thank you.
Okay, give me a minute, sorry.
Sir, we were in such a trance listening to your lecture.
Are you able to see my screen now?
Yes, sir.
Yes. So addition of LH is another alternative which can be given because it increases the androgen production, which then gets aromatized into estrogens and hence changes the intraovarian follicular milieu to a more estrogenic milieu. And this is a large randomized study which has looked at the safety of alpha in a poor responder, and they found that the incidence of total pregnancy outcome failure was lower in the FSH-LH combination group as compared to the FSH alone group. So addition of LH does help in treating patients who have low ovarian reserve. Now, should we add the LH in an antagonist cycle, because these studies were primarily based on the agonist protocols, but in an antagonist cycle where the patient has not been suppressed, there is not very much evidence whether this would really help, because they would have some endogenous LH production as well. So this LH essentially helps two subgroup of patients, one who have adequate pre-stimulation ovarian reserve, but have an unexpected hyporesponse to a FSH monotherapy, or to elderly women whose biopotency of this LH is lower. So in these two categories of patients, it would be better if you start adding LH, and ideally it should be added from the beginning of the stimulation. Now, what about increasing the dose mid-cycle? You give the stimulation, you monitor after 4 or 5 days, and you find that the response is not adequate. Should the patient be then put on an increasing dose from the mid-cycle? And there are many studies which have shown that increasing the dose in the middle of the cycle does not help, or there is a similar pregnancy rate. And there is a very logical reason behind this, that if you increase the dose on the 7th day, you will have modified baseline levels by day 10. So let us say you're given 7 days and you increase the dose. What you will do is you will recruit another cohort, which will start getting recruited 2 or 3 days later, and you will have 2 waves of follicles developing. So your aim of having one synchronized larger cohort is not achieved by increasing the dose midway. Your earlier cohort will continue to grow at a higher rate because these follicles have gone longer stimulation, and you will have a second cohort which is lagging by another 3 or 4 days, and this really does not help. So if you feel that the dose was inadequate, I would rather cancel that cycle and start a fresh cycle at a higher dose, because this increase in dose really does not help what you want to achieve. So increasing the dose during stimulation, the current evidence does not support changing the dose beyond day 6 of stimulation, because it does not lead to an improvement in the pregnancy outcomes. Now, what about the various adjuvants? And growth hormone was very extensively used maybe 10 years back, because it was thought that it has a synergistic effect like FSH on follicular development, predominantly because of its role through the insulin-like growth factor 1. But many RCTs have shown that there is no statistical difference in the outcomes, both in terms of pregnancy rates or in number of embryos or oocytes in patients receiving growth hormone versus those not receiving growth hormone. Another thing which is not uncommonly done is to convert a low responder IVF into an IUI cycle. Does this help? Again, 7 retrospective studies and 1 RCTs, which shows that even when there are 2 or more follicles, continuing with IVF has a better outcome rather than converting into an IUI. So unless the patient has only a single follicle, continuing with IVF is a better option than converting it into an IUI cycle. IUI might be cheaper, but the pregnancy rates would be equally poorer. So what are the other methods which are coming in? And there are this so-called duostim, where there is 1 follicular stimulation and 1 luteal stimulation. You could either do both in the same cycle, which is the classical duostim. You do a follicular stimulation, agonist trigger, and 5 days later you do the second stimulation. Or people have also done what is called the first luteal stim. You wait for the period and then you do the follicular stim. Both ways, the treatment cycle is shortened to 1 month. In one, you are doing a follicular stim followed by a luteal stim. In the other, you are doing a luteal stim followed by a follicular stim. The time required for both treatments is the same. The advantage of the second, that is luteal followed by follicular, is that you can do a fresh transfer following the second follicular stim, which cannot be done if you're doing a follicular versus the luteal stim. So people have achieved both the luteal phase ovarian stimulation versus follicular stimulation, and both are equally effective in terms of ovarian response. And this is the classical Ubaldi protocol, where you do the first stimulation, agonist trigger pickup, you wait for a period of 4 days, you start the second cycle, agonist trigger and a pickup. But this would result in a compulsory all freeze, because you are stimulating the patient in the luteal phase. And people have compared follicular phase versus duostim, and duostim does seem to have a slightly higher outcome in terms of number of oocytes and number of embryos, or number of euploid embryos that are generated. What about the trigger in these patients? And people have tried the dual trigger, where both the agonist and the HCG are given at the same time, or the double trigger, where the HCG and agonist are given at an interval of 6 hours, so 34 and 40 hours. There is not much of a difference between the two. I think both are more or less the same. And the thought behind this is that the agonist trigger gives rise to the LH and the FSH surge, whereas the HCG trigger only is an LH surrogate. So possibly the agonist trigger might give a slightly better outcome in terms of number of metaphase 2 oocytes. But this is traditionally reserved for patients who have an unexpected poor oocytes in terms of maturity. Then one can use the dual trigger. So the co-administration of the agonist with HCG studies have shown a few extra oocytes. So this is primarily for patients who have a low M2 rate or poor responders. The other thing which I had mentioned was about synchronization, because one of the challenges in poor responders is early follicular recruitment. And this can be achieved by putting the patient on estradiol. So you can either do the follicular estradiol synchronization, that is, you start the follicular, the estradiol from the second day of the period, or you can do the luteal phase estradiol, where you start the estradiol from the mid-luteal phase of the previous cycle. Both of this will prevent the early FSH rise and will lead to a more synchronous development. You could also put the patient on an oral contraceptive pill. However, the problem with pills in poor responders is that sometimes they cause profound suppression and the response is even worse. So if you want to give the pill, it should be given for between 12 to 16 days only, not for the full 21 days. And that brings us to the adjuvants and the newer options. And one of the most commonly tried and hotly debated is the role of dehydroepiandrosterone, DHEA, and androgens. Now, both of these essentially are precursors of androstenedione, and they help by increasing the intraovarian androgens, and they augment the E2 production by the granulosa cells. People who have attended the ESHRE this year have seen contradictory papers on the role of androgens. Some studies have shown it has a benefit, some studies have shown it does not have a benefit. So there is no consensus yet, but if you want to give this, you should give it in the previous cycles, ideally for 70-80 days, because that is the full cycle of ovarian, oocyte production before the second day of the period, and then you can assess the ovarian response. But there are lack of enough control studies. So as of now, no conclusive evidence whether this really helps, but this is one additional thing which can be tried in patients where nothing else has worked. But if you look at the Cochrane review, it concludes that there is still insufficient evidence. Coenzyme Q has also been tried, again given for a month or two in the previous cycles. These are primarily looking at rejuvenating the mitochondria and possibly helps by producing better quality oocytes rather than increasing the number of oocytes. Dr. Sunita has spoken extensively on ovarian rejuvenation, so I would not look into that, but this is both by PRP or by autologous bone marrow transplantation. These are early days. We need evidence, but someone has to do the good work. And once we have the data from all the studies that have been going on, we will know whether this works.
Hello, it is not audible.
Hello.
Hello.
Yes. That in which category of patient? And how do we go about it? So as of now, there is still insufficient evidence. So to summarize, the Poseidon strategy for these groups is that in group 1 and 2, you increase the dose of stimulation because the common reason for poor response is under-treatment, or the follicles could be asynchronous, so you do follicular synchronization. And so with estrogen pre-treatment, you use a protocol which has LH along with your FSH. In group 3 and 4, you try to optimize and get as many oocytes as you can because these patients are young. Even if the number of oocytes is low, she would still have a euploid embryo, and you could also do cryoaccumulation. Then the group 4 are the most difficult to treat because they are above 35, so they have poor quality as well as poor quantity. And here you just give a full scale conventional stimulation. So to conclude, chronological age is always the first step in ovarian reserve assessment because this is what is going to decide the quality. In young women, try to identify the poor responders because these are the women whom you can help by giving a slightly higher than conventional dose. In older women, identify those who have an acceptable chance of becoming pregnant. There is something called futility of treatment, and one should not treat every patient just because the patient wants it. Isolated tests may not help, and you should use a combination of tests to identify which patient needs what kind of treatment. So age is undeniably the strongest determinant, and this age-related decline in fertility is something which is unavoidable because with age, the quantity and the quality both decrease. And although the prognosis is bad in this older low responders, irrespective of the treatment modality that has been used, if you are able to pull oocytes from multiple cycles, you could still have that elusive single euploid embryo that could give a pregnancy to this patient. So once again, I thank ISAR for including me in this as a webinar, a very challenging topic, and I hope what I have shared helps you in your practice. Thank you very much.
Thank you, sir, for your excellent talk about the treatment of poor ovarian response. And I think we all are benefited and enlightened by your talk. And the treatment of the patient with expected poor ovarian reserve or response demands an individualized approach, including all steps of ART, including the choice of gonadotropin, dose and type of gonadotropins, and also the ovulation trigger and possible use of adjuvants. So although the treatment of patients with poor ovarian reserve still remains a therapeutic challenge, future perspectives suggest that there might be a light at the end of the tunnel. Thank you, sir, very much.
Thank you.
Thank you, Dr. Banker, sir. It was like attending 10 Escherichs. It was like flashback of Escherichs from 2010 to 2023. I mean, we could, and Purnima and I, we were making the PPT for the panel discussion. Everything you talked was something in our slides. And I'm sure Purnima and I, we are so happy you have given so many answers. I mean, it was wonderful. The topic was so tough, but you have made it so simple. And I'm sure everybody who has listened to you will carry home these points or carry these points home for practice, change in practice, and not doing what is, unnecessary. Thank you, sir.
Thank you.
Dr. Purnima, we can start the third session, please.
Yes, ma'am. Yes. For our third session, I would like to invite our chairperson, Dr. Babita Panda ma'am. Ma'am is former professor in HOD IVF unit, IMS and SUM Hospital BBSR, former consultant, reproductive medicine, CMC Vellore, former consultant, SCB Medical College, Qatar. Ma'am is manager director and chief IVF consultant of Future Fertility Private Limited, Odisha, ex-professor in HOD IVF unit, SUM Hospital, and recipient of Young Scientist Award in 1999 from SCB Medical College, Cuttack, and has many research and publication into her credit, and has done advanced training in ART, ultrasound, and operative laparoscopy. I welcome you, ma'am, on this platform, Dr. Babita Panda ma'am. And I would like to invite our second chairperson, Dr. Bharti Mishra ma'am. Ma'am is ex-HOD of OG, MKCG, MCH, and PRM, MCH, and is PG and UG examiner, has many publications, and recipient of Wonder Foxian Award, Teacher Par Excellence Award, and has many oration into her credit. I welcome you, ma'am, on this platform. Thank you for joining us. So I would like to hand over the session to our chairperson for introduction of our next speaker, Dr. Sujata Kar, ma'am. Dr.
I think
Bharti,
my introduction is over, but madam is my best friend and critique and everything. So I'm sure she'll have 2 words for me.
Yes. Am I audible? I am audible and visible. Hello,
Yes,
Sujata.
madam.
Yes, ma'am.
Okay. If not audible, if not visible, I am audible for it. So I miss Sunita. I was there. but I could not chair her session because I joined in the middle. And Sunita, it was excellent. And you are the eligible diamond of Pune, not Pune, of whole India. And your academic excellence and your research attitude is inspiring so many of us to follow your line. So you should be ideally our leader. Now, over to Sujata. What to tell about Sujata? And she's a gem, not only from Odisha, she's known throughout the world for her achievement. And she has done so many pioneer works in IVF and ART in her place in Bhubaneswar. And she's a colleague and friend of mine. And she's been so academic, we are seeing in all conferences. So I don't want to, between her and me, on the screen, I want to present her paper nicely. Thank you. Wish you all the best, Sujata, and blessings.
Thank you, madam. Thank you very much.
I am not busy. I'm busy. Okay, over to you. What topic you are giving now?
So I'm just going to speak about all okay. Am I visible and audible?
Yeah.
Okay. And before I start, thank you very much, Monica and Dr. Purnima, for organizing this fabulous, series of webinars, ISAR Perfection series. And not only just making this program and running it, it's the way you run it is like amazing. You are like a robo who has to do her work perfectly, and each and everything. I am not saying this for the sake of saying this on a webinar, although I haven't connected to you over last couple of months about this webinar, but I've been noticing the way you both, at least now that I can see Dr. Purnima also, and others who are all involved of the MP chapter. I'm sure you have a good team with you, but with you two in the forefront, I think you are doing an excellent job. And I love the logo. The first time I saw it, I said, fabulous. How didn't I think of this one? And so I'm sure it's an ongoing, I'm sure, and it's an excellent program. And thank you for involving Orissa chapter this time. I mean, we have a good set of people here who are academically inclined and do a lot of IVF work. I am sure many of them who have logged in today will benefit a lot from your series. And for the other series also, I will be, we do post in our groups whatever you send, but I'm sure we shall do it in future also for all your other programs. So let me start off. So today's topic, as Monica said, was about diminished ovarian reserve, or rather poor responders. And that is why she wanted me to speak. I thought two stalwarts like Sunita, who has covered all the recent advances and all that is not only experimental, but now slowly becoming mainstream in ovarian rejuvenation. Sunita has covered all that, and Dr. Manish Pankar, who is generally an excellent and a thorough speaker. Whatever topic given to him, he has also covered a lot. So I was wondering, what then else can I cover? And so we decided on me covering a little bit about the art of ovarian stimulation. And I thought that I will talk about novel ovarian stimulation protocols, and that would be excellent in the sense that it will cover in its entirety a lot about what women of older age and women with diminished ovarian reserve or diminished ovarian output sensitivity would benefit. So I hope, Monica, that you will be satisfied with my the content of my my talk. So let's say that implantation for us IVF consultants, implantation is the last frontier to conquer. We've come a long way in the last 40 years, and we know that the phenomenon of endometrial receptivity and trophoblastic invasion is currently considered the major limiting factor in establishing a pregnancy via IVF. Now, although IVF has been there for 40 years now, and we've come a long way, but still, despite considerable improvements in technologies, the ART process remains inefficient, with overall live birth rates per oocyte retrieved reported to be as low as 5 to 10%. This is per oocyte retrieved. Only about 40 to 60% of couples visiting infertility centers will achieve the desired goal of a live birth following their treatment. And this is from this very recent 2022 paper that I have quoted here. So the risk of ovarian hyperstimulation syndrome and multiple pregnancy, in addition to a potentially higher prevalence of certain birth defect, also is another factor which we haven't really got rid of. So in my lecture today, I'll be talking about how to optimize the ovarian stimulation, and which we need mostly for our poor responders as well as normal responders. So how to I'll divide my lecture into how to optimize early follicular phase, how to optimize pre-luteal phase, luteal and random start stimulations, and a little bit about trigger and how trigger can improve our chances of a better outcome of IVF stimulation. Now, what are the novel stimulation? Now we know that the new stimulation approaches, together with the advanced cryopreservation technique, has allowed for a total disarticulation between the menstrual cycle, ovarian stimulation starting, and the embryo transfer. They do not anymore have to be together, or neither do we have to plan them together. And so there are so many new novel approaches that have come in, and most of them will be utilizing a GnRH antagonist protocol, and which goes on and which will go on in refinement and improvement, which is going to go on. Now, before I start my talk, I just want to, although Manish has covered it, I want to little bit again remind you of the concept of FORT versus FOI, which talks about ovarian reserve and ovarian sensitivity. So ovarian responsiveness is generally assessed by ovarian markers such as antral follicle count and AMH in conjunction with age, in order to predict a poor, normal, or a hyper response. This is the standard thing that we have been doing for all this time. However, patients with unexpected poor response, which belong to the Poseidon group 1 and 2, have a normal ovarian response markers or ovarian reserve markers, and therefore it is difficult to predict their response based on standard testing. But still, we wouldn't know how they will respond till we actually stimulate them. So the concept of follicle output rate and follicle to oocyte index has come in, which is, if you are talking about follicle to oocyte index, a follicle to oocyte index is the number of oocytes you retrieved at egg collection versus the number of follicles that you saw on the day 2, beginning of the stimulation, which is the antral follicle count. And FORT is the pre-ovulatory follicle count on the day of HCG versus AFC. As it is obvious, FOI is a better indicator, because with FOI, you actually are counting and looking at the number of oocytes that we got versus what we were expecting with the antral follicle count of that day. And a normal FOI would be, if anything, more than 50% we get of what antral follicle count we see. So this is another pictorial depiction of a good ovarian reserve. See how the antral follicle counts are good. AMH is very good. However, a poor ovarian response, you do not get the number of eggs that you expect. And a poor ovarian reserve or a diminished ovarian reserve, who has everything is low, you are expecting her to be poor. You expect her 4-5 oocytes, but you get as good as you expect. So that's a good ovarian response. So this is a concept which we need to understand. So as the GnRH antagonist protocol lacks the process of pituitary down regulation, the endogenous follicle FSH level is not inhibited, and the transient increase in endogenous FSH during the luteofollicular transition recruits early antral follicles, thereby affecting the follicles. So we know although the antagonists have become almost mainstay now, and more number of cycles we are doing is as antagonists, but antagonists do have a lot of disadvantages even now. The major one being that it does not completely inhibit the endogenous hormones, and therefore the synchronization of follicle, the breakthrough growth of a follicle, the breakthrough LH surge, all these things are very much possibility with these protocols. And where ovarian stimulation is concerned, and understanding various aspects of ovarian stimulation, it is so difficult. The more you try to understand, the more new protocols you hear, the more you learn about ovulation induction and the menstrual cycle, because apparently this graph that is ingrained in our mind since our MBBS days, but there is so much to it than a simple graph that we had all learned during our MBBS days. So my first was about how to optimize luteofollicular transition phase, which means the phase which comes before the menstrual cycle of a certain cycle from which you plan to do a stimulation. You'll start stimulation from day 2 or day 3 of that cycle. So there are 3 options that I have put in here. I'm sure there are many. This is just my compilation that I have done. One is to add estradiol valerate. One is to add antagonist premenstrual, and the other is to add androgens. These are the 3 options that we can take to optimize a recruitment of a follicle and to make sure that the premenstrual rise in FSH which occurs in the luteofollicular transition phase is blocked. So you can give an estradiol valerate any time from 1 week to 10 days just before your expected menses, and then start the stimulation. That is one way. You can give antagonists for about same 4 to 5 days, day 25 to day 30 of your cycle of the expected menses, or you could add androgens in the previous luteal phase. So addition of androgens is also now becoming accepted, and there is evidence which seem to support one of these methods to improve diminished ovarian reserve. So androgens have a parakine action in the early follicular phase. It is a substrate for estrogens in the granulosa cells. It also increases the FSH receptor expression. We know that all the follicles, or the antral follicles, when they are in a stage when they are not responsive to FSH, and then they transit to a phase when they become FSH responsive, they start responding to FSH, which means they start expressing the FSH receptors, and that transition in follicular androgens is of importance. And so we also have evidence from primates that suggests that androgens can reduce apoptosis. So not only can it increase or change the intrafollicular milieu by making it more androgenic, and by that helping by making it helping in expression of the FSH receptors, but it can also reduce the apoptosis that goes on in the growth phase. We know that millions of follicles enter the growth phase, and majority of them undergo apoptosis. Only a very few, counted few, are recruited into the cycle, and when we know only one of them becomes dominant in a natural cycle. So this is one way. So there are again various ways you can boost intra-ovarian androgens and recruitments. Dr. Manish has covered, so I won't take too much time on it. You could give a testosterone gel on the skin before 10 days, 15 days before the stimulation cycle. You could add recombinant LH, although this is not a practical thing that we often do. I personally have no experience. Testosterone gel, we all do. I do it in my poor response, expected poor response patients. DHEA is another big chapter, which I'm sure the panel is going to cover and ask you questions on the recent evidence, etc. So all these are 3 choices we can take prior to FSH stimulation in an effort to boost intra-ovarian androgens and to increase recruitment of the follicles. LH also has been shown. For 7 days you could give LH. For testosterone gel you could give for about 15 to 20 days pre-menstruous in the luteo follicular transition phase, and then start your cycle. So this is one way to optimize the luteo follicular transition phase of the previous cycle. Now, the second was how to optimize the early follicular phase. This is the phase when already recruitment has occurred, and still you could do some things as a IVF a reproductive endocrinologist to get the best possible response. So what are the possible things that we could do? One is cycle. We very often do cycle scheduling for optimizing timing and selected cohort. This is something which we do, but oral pills we have been using for years together. Now we know that all of us are starting to go away from oral pills, and so progesterone we add to make your to get your cycle, which probably is a better choice. Estradiol valproate also may be used. Basal hormone levels at the start of ovarian stimulation. This is not at all something which is recommended by societies or recommended by guidelines that we have, but to optimize a cycle and to plan different strategies. Many of us would want to do this in our special cases where this might help us in, fine-tuning the ovarian stimulation. 3 days of antagonist before stimulation, which means after she gets the period, and day 1, day 2, day 3 is another choice that we take often to, better recruit, better synchronize the follicle. Apart from the fact that this can be done to time your, better timing your cycle when you want to stimulate, if the patient gets some menses early and sting dilate, but it might also help in synchronizing the follicular growth better. And of course, another strategy which we could do in the early follicular phase is to do a day 2 AFC in the stimulation cycle to optimize the FSH dose. Now we know that especially in our diminished reserve women, or those who are poor responders in IVF, expected poor response or known poor response, we know that antral follicle count may vary from cycle to cycle. In fact, sometimes earlier on, what one used to do is every cycle you keep seeing antral follicles, and the cycle in which she shows a good number of better number of antral follicles, let's say, and accordingly you decide to stimulate her on that cycle. Now also we do so often. Poor patient response patient 40 plus, we say, okay, we'll do a day 2 AFC. If we find at least 2-3 follicles, then we shall still take up that cycle for your IVF. If we don't, we might not want to do that and again try the next cycle. So doing a day 2 on the cycle day AFC on the cycle that you plan FSH might make you decide to do or not to do, and also to optimize the FSH dose. So these are some of the methods to optimize your early follicular phase. Then comes the follicular phase of ovarian stimulation cycle, how to optimize it for synchronization of maximal optimal follicle numbers. So 3 days of antagonist, like I said, this is the pictorial depiction. Another option is to do AACEP protocol. So in this, you give a agonist, antagonist, and sometimes you might even add a estradiol before that. So this is also a protocol many people follow for doing in poor responder patients. So prolonged agonist, we know that can oversuppress. And ovarian response to gonadotropins by completely binding with FSH receptors on follicle. So prolonged agonist probably is also not acceptable for poor responders. So low dose antagonists can be started with menses. That also one can do. Very low dose antagonist. This is not very common, but one can do a agonist stop cycle, which means you give a little bit of agonist and then you convert to antagonist. And then of course you could also add 10 days of estradiol. So this is called ACP or AACEP protocol, in which estrogen priming along with agonist antagonist cycle together can improve your chances of this is the pictorial depiction of how we could give estrogen priming along with an agonist which you stop, and then a antagonist either in very low dose throughout the cycle, or you give it in a regular way in which we give. So that was my third part of my talk. And then is the preventing the LH surge. This is the other main important aspect of the ovarian stimulation cycles that we do for our assisted reproductive technologies. And we know today that the progestin primed ovarian stimulation has become pretty, acceptable into mainstream practice. So this is not only for poor ovarian, it doesn't have to be for poor ovarian response. It can be for normal responders. It can be for donor cycles. It can be for hyper responders. But this is a concept which needs a little time for us to understand, and so that we can accept it into our practice. So we know that GnRH analogs has multiple disadvantages, while GnRH antagonists produce rapid and reversible LH suppression with no initial flare effect. A varied proportion, let's say from less than 1% to 38% of patients using an antagonist experience a premature LH surge. So that's a big number. And so which means that we will be facing it often in our day-to-day practice, especially older patients and patients with diminished ovarian reserve. Therefore, there is an unmet need for new methods with improved efficacy, safety profile, and user convenience to block the LH surge. And so it happens, we know already that, the steroidal preparations, whether it's estrogen or it's progesterone or it's the oral contraceptive pills, they are able to modulate the pituitary gonadotrophin secretion. We know that pituitary will be blocked if the estrogens are very high. We know progesterones can block the pituitary secretion of gonadotrophins, etc. So the synthetic progestin sharply decreases both serum FSH LH values with recovery of normal basal levels after a 5-day washout period. So LH suppression, progesterone, which uses an LH suppression effects, and the freeze-all protocol efficacy suggests that progesterone may be used as an alternative to a GnRH analog for suppressing premature ovarian surge, or it can also, be a replacement for an antagonist. PPOS regimen should be used in cases with basal E2 levels of no more than 50 to 70 picograms, and medroxyprogesterone acetate. There's so many progestins, but medroxyprogesterone acetate seems to have found there are other studies to show why this is so, but I will not be showing you all that. But it is a very strong major advantages of using medroxyprogesterone and not other progesterones for PPOS protocols is that it is not only a strong progestogenic action, it has fewer androgenic properties and does not interfere with the measurement of endogenous progesterone production. So that is a very big advantage. And this is a pictorial depiction of how we add the progesterone for PPOS cycle. So these are the various other progesterones. I'm not going to go into the details, which can be used as progestin. So you can imagine how much it reduces the injections and how much the cost, etc. for the patient if you're using a progesterone for your suppressing the LH surge. Now, the one major disadvantage of the prolonged exposure, one major concern for the PPOS was some studies have reported concern about prolonged exposure to the developing follicles to progesterone. So elevated progesterone concentrations on the day of oocyte maturation induction have in fact been said to significantly reduce the formation and rate of top quality blastocysts. So this is an area which is still debatable and an area in which a lot of research is still going on. But then meanwhile, PPOS has become pretty mainstream with many of us already into it strongly. So this is probably the best indication for fertility preservation cycles, donor cycles, PGT cycles, PCOS where you're doing a freeze-all, luteal and random start cycles, because this is cheap, patient-friendly, easy access, better LH surge control, even compared to antagonist or agonist. And we have quite a few of, evidence to support that also. Then the next part of my talk was about random start and luteal phase ovarian stimulation. Again, as I told you, that understanding the ovarian cycle or the menstrual cycle is so complicated. For example, our concept during MBBS studies was something totally different. And now that you start doing more and more of IVF and start reading more and more about this, you learn new things every day. So recent research has suggested that recruitable antral follicles are constantly present in the ovaries during the menstrual cycle. And ultrasonographic studies have demonstrated multiple cohorts or waves of 2 or 5 follicles are recruited continuously throughout the menstrual cycle. A wave is a synchronous growth of follicles that have similar diameter. Waves of follicular development have been documented in healthy women during ultrasound, because now we are doing very advanced ultrasound, which have much more, accurately the imaging capability. So we have seen that it's not just once that you can recruit a cycle. A maximum, maybe 2 or 3 further waves happen even during the luteal phase when follicular growth is not expected. So this new discovery has led to some new concepts in doing ovulation induction, ovarian stimulation, and specifically for certain category of women. This is a pictorial depiction of how you have people have found follicular waves. Here 2 waves are there. Here you can see 3 waves during the menstrual cycle. A follicular wave that emerges in the early to mid follicular phase is ovulatory, while the other waves emerging in the luteal phase are usually anovulatory. They do not ovulate. They do not result in ovulation in a natural cycle, but they are a recruitable follicle. And in fact, the recruitable window is longer in the luteal phase. So these are new concepts that we are learning. And so we have immediately got hold of these new concepts. And now we have luteal start protocols. Who will need luteal start protocol? I will come shortly. But FSH 1 or 2 days after ovulation, between days 15 to 20, one way you can use clomiphene HMG or you can use HMG alone. Implantation rate and oocyte numbers are comparable. Higher dose of stimulation and longer duration may be there. And this is the most appropriate for fertility preservation options where you don't have much time. So patient comes in with diagnosis of malignancy and you can random start her cycle, even if she is in the luteal phase. And it can also be used for poor responders, also in normal cycles. This luteal start protocols can be used. So luteal stimulation, whether endogenous progesterone can block LH surge. This is a fantastic concept, because when we are doing luteal stimulation, at that time we know that the patient already has a corpus luteum from her previous cycle. Is that enough to block the LH surge? That's another big question, and again another debatable. I am sure slowly we'll learn to understand. Random start, like I said, it is showing good evidence. We have good number of studies to show us that, and it has also been starting to use often by patients who are undergoing fertility preservation. And another concept with the same lines is double or dual stimulation, which means in one cycle you stimulate them twice. This is also used, can be used for poor response or those who have diminished ovarian reserve. You can use those because in one cycle with a shorter duration, you can collect more number of oocytes and you can collect more number of, create more number of embryos, blastocysts for your PGT cycles if a woman has a possibility of going through a dual stimulation. And dual stimulation in a random start cycle also is possible. So various options and possibilities have been thrown open when the fact happened that we could totally disarticulate. So we can do all that. So that's excellent. Indication for these are, as I have already mentioned, all these category of women we could use. Now the trigger is which is a matter which is very, very important. For so many years we were using LH or we were using a HCG trigger, which is standard, gold standard in fact. Using an HCG trigger. After we learned to suppress or to eliminate OHSs, we started giving recombinant LH. But the agonist became a paradigm shift, because if you understand the nature of the trigger, where and how we are triggering is what is most important. And with the agonist trigger, we are doing it right, where the nature has meant it to be used as a trigger. So agonist was a paradigm shift, and the rationale for a double trigger also comes in here. Using an agonist trigger also will have lots of other advantages possibly, which which means that it could improve the number of M2 oocytes and quality. Of course, we will freeze the embryos, but another advantage would be that it possibly improves M2 oocytes. And using a double trigger, or to use both FSH, both HCG and agonist, also has a lot of rationale to improve our IVF cycle outcome, because the rationale is that spontaneous ovulation is preceded by a surge of both FSH and LH. We know that there's a very small FSH rise and then a larger LH rise in a natural cycle and that is why it is important, because this double trigger mimics a natural cycle much better than our other triggers. So not only for a hyper responder, not only for avoiding OHSS, we can use a double trigger with this rationale to improve our chances. So here is a pictorial depiction of how the natural LH surge is best mimicked by the GnRH agonist. So I think I'm almost up and crossing my time. So I think I will just end my talk by saying that all these newer techniques we are, digging into various things, even looking for a needle in a haystack, how we can improve getting even one more oocyte from each of our patients of poor response. But unfortunately, still now, we do not have any way to completely identify a poor responder. And until genotypic profiling of a relevant polymorphisms are widely available to identify patients with unexpected poor response to gonadotrophin stimulations, follicles, models like FORT and FY might help, but still we will have a long way to go before we completely use precision medicine to stimulate our patients of poor response, or any IVF patient for that matter. And this was a fantastic study which was reported, which was published by Jacques Cohen et al. And they predicted that with the amount of success that or advance that we have made in IVF in the last 40 years, if we progress like this, probably a time will come, possibly by 2053, when we will have 100% implantation rate for all our patients. So thank you very much once again, and I will take this opportunity to invite all of you to join us for the ISAR 2024, February 3rd, 4th and 5th in Bhubaneswar. Our team, all those who are here today, whether it's my chairpersons, which is Dr. Bharti Mishra and Dr. Babita Panda, or it is my secretary, Dr. Madhumita Mahanti, or the entire group of our consultants, our people in Orissa are going to make a big success, and inviting you all to join us. Thank you so much.
Thank you. Thank you, Sujata. Thank you, Sujata. We are there with you. And my video is not. Am I audible?
Yes, madam. Yes, madam.
Okay. Thank you, Sujata. We are all with you wholeheartedly. We'll support you. Whatever work you will assign to us, we'll be doing that. And very nice talk. One question from my side. Have you studied, because you are always the research minded and you calculate and you also do all the obstetric management, different protocol for poor responder, does it affect your obstetrical outcome?
No, I don't know. I am not aware of protocol affecting obstetric outcome. We know that fresh embryo transfer, frozen embryo transfer, that itself will affect. But I am not aware of a stimulation protocol affecting obstetric outcome.
That's what means. How many abortion, whether any more congenital anomalies or many perineum labor, or is there any effect?
Madam, not related to
no, as such in IVF, it is affected. But is it more affected by different protocol, or it is same as the usual protocol?
I think it is same in all protocols, madam, to the best of my knowledge.
You have to study this because long-term effect you don't know, because you are using medroxy and you told that you are antagonist, and by both the times you are giving LH, all these things.
Madam, in all these protocols, we will never do a fresh embryo transfer. It will always be a frozen embryo transfer. So we
what
will
is the
freeze all the embryos and then optimize the patient.
a frozen embryo over fresh in these cases? I want to know.
In these novel protocols, we cannot use, we can almost never use a fresh transfer. Almost never.
Okay.
We will almost always be using a frozen.
So now everything, all the queries and everything, appreciation there in the chart, and we'll know, come to know, and she will be answering later. So now we'll proceed to the next speaker, isn't it?
Yes, ma'am.
And they have made static. Okay.
Thank you, Mishra ma'am, for making the session so electric and sparked. And Sujata ma'am, your talk was like perfect combination to Banker sir's talk. There he gave us all the
tried my
introduction,
best.
and then you started firing from the border, you know. It was continuous firing. So many things went, all our electrical connections in the neurons were all, you know, charged up. So madam, I just want to ask you, the fantastic term you used was disarticulation of the IVF cycle. That was such a beautiful term. I think it should come in literature also. Ma'am, what you talked about the AACP cycle, where in the same cycle we are using agonist, stop, and then antagonist. It is same as 10 years back we were talking about sandwich protocol. Is it same or is it something different? Because
I am not, I haven't heard. What was sandwich protocol?
Sandwich protocol was also like agonist, antagonist in the same cycle, but I never used it. So I'm not aware. But I was just one. And ma'am, another protocol was microdose flare agonist protocol. Remember?
Microdose flare is different.
That is
different. So in microdose flare, you start from day 1 of the cycle, very, very low dose. I mean, probably 1 or 2 international units or something like that we used to give. I have not done it for a long time, forgetting. Or 3 or 5 something in the morning, evening, twice, microdose flare.
Yes.
And you started from day 1. It is like a short protocol, only it's very, very low.
Yes, ma'am. And answering, I was just trying to comment on Mishra madam's concern that are these new technologies going to give us some problems later on after 1 or 2 decades when these children who are born through IVF, they enter their reproductive life. So, madam, just my only concern was the frozen embryo transfer, because Dr. Rishikesh Pai and so many other learned speakers have talked about epigenetic changes. So, epigenetics is something which is not by DNA and the chromosomes. Epigenetics through some strange mechanism of metabolic disturbances in the embryo, which are put in a liquid nitrogen for so long a time, and then they are taken out and thawed. So these babies who are born through FET might show some sort of epigenetic changes after 1 or 2 decades, about which we might have to consider whether we want to do FET freeze for all, or we have to have some little bit proportion of fresh transfers.
No doubt about it.
So ma'am, we are there.
There's so much we don't know yet.
Yes, ma'am. Yes.
Even if you look at the progesterone only protocol, so standard ovarian cycle tells us what? There is no progesterone in the first half when the follicle and the oocyte is becoming mature. Only after release of the oocyte does the progesterone start rising. So during the follicular growth and during the maturation process of the oocyte, if there is such high dosage of progesterone in the system, those also can induce changes in the oocyte. So there is a lot of concern about that also. Only we don't have any concrete evidence as of.
Yes, ma'am. Good. Ma'am, I think we are in ART, we are there. I mean, I think Purnima is again 15 years behind us. So probably every decade will bring us changes, which we will be there to witness for a long time.
Absolutely.
Thank you so much, ma'am.
Thank you so much.
And
thanks a ton.
So publication and reporting and documenting. You document and you also document the children. Let them be follow up, as you have told, that there should be all the children of IVF, whether frozen or like that or a simple protocol, should be followed up for long-standing effect. We are happy, positive things. We'll know. We can tell more.
Yes, ma'am. And
Okay.
ISAR office bearers can help us, all the
Yes.
young doctors and scientists, and even people like us who want to present studies. If ISAR can give us the platform of ethics clearance and
No, you have to learn
CRI
from Sunita.
registration,
How
multi-centric
Sunita have
studies.
done that. You told her rejuvenated one group he has done, and that's a group she has started. So you start, all of the ART people start. ART babies follow one group. You
So
put your
ethical clearance is not a
we'll be doing
problem at all. You can get ethical clearance from any center.
Yes.
You can
Okay.
get it cleared from other center also.
And CTRI registration, ma'am. CTRI
Yes.
central. The trial registration of India has to be cleared. And of
Yes.
course, the
You have to
starting
just
of the
upload it in the trial. But if you're doing a randomized trial or any trial, you just have to register in the CTRI site, which is very simple. You don't have to do anything, but you have to have an ethics committee clearance. Ethics committee clearance, if you have of your own center or your own hospital, very good. If you don't have, you can always apply to a ethics committee of any other hospital for a study and get a clearance.
No,
You
we
have
are
to pay
having
the
a committee of our own college, medical college, not for ART, IVF, for
Yes.
everything, for all
Yeah,
cases, all registration we are having. So for that reason, you must be having in your own institute, because your institute is like a medical college. Okay. Thanks. Bye. God bless you.
Thank you. Thank you.
Thank you.
Ma'am.
Thank you.
Thank you, Sujata ma'am. And I request Dr. Vishal. Dr. Vishal is there with us. Dr. Vishal Dave, please can you start the panel discussion with myself and Dr. Purnima?
Now, this is the fourth session. We are doing a panel discussion. Panel discussion regarding challenging cases of poor responders in clinical practice. For this, we have two moderators, Dr. Monica Singh, madam, and Dr. Purnima Tiwari, madam. So I hand over the session to Dr. Monica Singh.
Thank you. Thank you so much, Dr. Vishal. And thank you, INTAS, for giving us this academic platform. I invite Dr. Purnima, my co-moderator, to please invite the panelists.
Yes, ma'am. Dr. Vishal, can we have the CV
Yes.
of panelist? So I would like to invite Dr. Arun Kumar Singh, sir. Sir has done fellowship in IVF and reproductive medicine and is director at Pratiksha Fertility and IVF Clinic, Balasore, and visiting consultant Jyoti Missionary Hospital, ex-assistant professor Atra Medical College, joint secretary Iluru Obs Gynae Society, secretary North Odisha Obstetric Gynae Society, and member of FOXY ISAR IFS IAGE. I welcome you, sir, on this platform as our panelist. Dr. Arun Kumar Singh, sir.
Thank you. Good evening.
Yes, good evening, sir. Thank you so much for joining us, sir. And I would like to invite our second panelist, Dr. Lipsa Mishra, ma'am. Ma'am is an alumni of SCB Medical College, Cuttack, and has done fellowship in reproductive medicine from Indira IVF, Udaipur, and has various publications in national journals. And ma'am has area of interest in so many areas of infertility and has experience of more than 5 years. I welcome you, ma'am, on this platform. Dr. Lipsa Mishra, ma'am.
Thank you so much, madam.
Thank you, ma'am. So our next panelist is Dr. Lipika Morana, ma'am. Ma'am actually has just sent a message that due to unavoidable circumstances, ma'am will not be able to join this panel discussion. Dr. Monica, ma'am.
Yes, we can skip to the next panelist.
Next panelist is Dr. Madhumita Mohanty, ma'am. Ma'am is an alumni of SCB Medical College, Cuttack, and Kastuba Medical College, Manipal. She is consultant sonologist and laparoscopist and having a special interest in ultrasound and infertility, and member of FOXY and IMS, ex-secretary IAG Odisha, present secretary of ISAR Odisha, and works for the upliftment of health issues of women and Odisha. I welcome you, Dr. Madhumita Mohanty, ma'am, and my great pleasure to invite you. Dr. Madhumita, ma'am.
Thank you and good evening to all of you here. Thank you.
Thank you, ma'am, for joining us. Next panelist is Dr. Rohini Naik, ma'am. Ma'am has done FRM from Natkani Academic JIS NH and joint secretary of IFS Odisha chapter, life member of FOXY ISAR IFS AOGO, and has various publications in reputed journals and has been awarded Best Paper Award in FOXY 2017 and has more than 7 years of experience. and is consultant at Birla Fertility and IVF, Bhubaneswar. Dr. Rohini Naik, ma'am, I welcome you, ma'am. Thank you for joining us. Dr. Rohini, ma'am.
Yes, thank you.
Next panelist is Dr. Sasmita Naik, ma'am. Ma'am is Center Head and Chief Fertility Specialist at Indra IVF, Bhubaneswar, and is an alumni of MKCG Medical College, Berhampur, Odisha. Has done fellowship in reproductive medicine, ex-consultant, Santan Fertility and Research Center, and won first position in various clinical case presentation, UG and PG career, and has more than 9 years of experience in field of reproductive medicine, and has delivered many scientific talk in various state and national level scientific sessions. I welcome you, Dr. Sasmita Naik, ma'am. Thank you for joining us. Dr. Sasmita.
Thank you. A very good evening to all.
Yes, good evening, ma'am. Next, I also welcome Dr. Shakti Kumar Tripathi, sir. Sir has just sent a message that due to some circumstances, sir might join little late.
So you can introduce sir in a few lines and we will wait for him if he joins. There is an inspection in his center, I think.
Yes, ma'am. There is some inspection going on. Yes. Sir is an alumni of SCB Medical College, Cuttack, and has done fellowship in reproductive medicine, minimal invasive surgery, International College of Robotic Surgeon, fellowship in advanced ultrasound colposcopy, diploma in reproductive medicine, and so many academic credits into academic achievements into Sir credit. Sir is presently working as fertility consultant at Kishori Hospital and IVF Center, Bargar. And sir is National Awardee, Foxy Best Paper, Srimati Bhagwati Devi Prize, Journal Awardee Best Poster, Yuva Foxy, and has more than 5 years of experience in IVF and fertility enhancing laparoscopic surgery. So I welcome you, sir, on this platform. Dr. Shakti Kumar Tripathi, sir. Sir might be joining, I think, in few minutes, ma'am.
Okay, okay. So can I have the presenter rights, Dr. Vishal?
Yes, already we have stopped sharing.
Okay, so I'll share the screen. I'm not getting access to my desktop. Allow, okay.
Are you able to open it?
Yeah, yeah. Now, is the screen visible?
No, ma'am.
It's not visible? Okay, it has opened. Okay. So I think I'll try once more. Otherwise, Purnima, you share. It's actually a new laptop, so that's why it's allowing, it's not giving me permission. Zoom. I'll call you.
Should I share it, ma'am?
Yeah, please share. I'll just exit. So how do I give her my rights of sharing, Vishal?
Is it visible now?
Yeah. Okay, fine. So let us start from the beginning and put it on slide share.
Yes.
Slideshow. Okay. So good evening, dear panelists. We are at the end of these very informative lectures, which spanned from ovarian rejuvenation on one end and the journey through management of poor responders by Dr. Banker, and some very smart and innovative stimulation protocols by Dr. Sujata Kar ma'am, we are now at the beginning of a panel which will ask you questions based on these lectures and a few more questions. Next. So I thank ISAR Perfection Series and all my panelists for being a part of this show. Can we go to case number 1? So case number 1, as you have been already intimated in the WhatsApp group, that this will be Poseidon case-based discussion. So this woman is 34 years old and she has primary infertility since 4 years. And she, in the meantime, underwent 3 IUI cycles with gonadotropins, but failed to conceive. And when she comes to your IVF center, she has an AMH of 1, normal TSH, AFC of 3 to 4, and semen analysis of husband is normal. Next. So can Dr. Arun Singh tell me which Poseidon group does this particular patient belong to, and why do we do Poseidon? What is the definite advantage that Poseidon criteria gives us over Bologna criteria?
Yeah, this is one patient was less than 35 years and AMH and AFC are also low. So she is Poseidon group 3. The criteria, because of Bologna criteria, it does not cover the heterogeneous group of populations. It only tells around more than 40 years of age population, only tells regarding at a time, it does not encompass all the things like heterogeneity of the population. So that's why Poseidon is preferred over the Bologna criteria.
Yes. So she is definitely Poseidon 3, and Bologna criteria went for a homogeneous population distribution. So we cannot have the patient management guidelines from it, and it is very old. It is almost 12 years old.
And it also does not tell about the prognosis part, Bologna criteria.
Next slide. So you are dealing with a Poseidon group 3, who is an expected poor responder. So you have told us the advantage of stratification. So what is the basic aim of Poseidon criteria, Dr. Singh? The basic aim
is to give a one single euploid embryo to the patient. So that that is the basic aim, to give a single euploid embryo.
Yes, actually it is a single euploid. Actually the Poseidon, when it the group decides upon the ART calculator, they tell us to make so many, retrieve so many oocytes because their aim is to get one euploid blastocyst. So can you tell me the full form of Poseidon? What is the abbreviation stands for?
Patient-oriented strategies encompassing individualized oocyte number.
Yeah, and that is excellent, because when I started learning this abbreviation, I had to memorize it at least 12 times before I could memorize it, you know. This was, I'm talking about 8 years back, but now we all know it by heart. Next slide. So Dr. Singh, now I think we'll go to Dr. Lipsa. Dr. Lipsa is there?
Yes, madam.
Yeah, Lipsa, can you tell us, out of all the patients walking into your clinic, how many are poor responders?
Ma'am, in the last, I think, half a decade, the percentage of these, the poor ovarian reserve patients, they are on the rise. And presently, I might say that around 50 to 60% of the patients I'm seeing in a regular OPD basis are having AFC of, less than 5, almost 50 to 60%. So it falls like both the young age and the old age, like I can say the Poseidon group 3 and 4. They are comprising almost more than half of the patients I'm seeing regularly.
Okay, actually it is not 3 and 4, it is 2 and 4.
Oh, sorry, yeah, sorry. Yes,
So,
2 and 4.
Poseidon can be divided vertically and horizontally. If you divide the Poseidon diagram horizontally, above the line is the unexpected poor responders, and below the horizontal line is the expected poor responders. And if you divide it vertically, then 1 and 3 are the young patients below 35, and 2 and 4 are the older patients. So almost you can see more than 3 your patients are Poseidon 2 and 4, which is a very large number and a tough group to tackle.
Right.
So next slide, Purnima. Gonadotropin starting dose and regime can be determined through this stratification. And this is just for general information, which we'll cover later on. So we can go to the next slide. Now, Dr. Lipsa, I'll ask you again, which ovarian reserve test would you do in Poseidon in these poor responder patients? Now, I'm not talking about only the patient who has come to you. In general, a patient comes to you and you want to know her Poseidon group. What ovarian reserve test do you prefer? We have already listened it in the lectures.
Yes. So the two most common tests which we do is a transvaginal scan for knowing the antral follicle count, and the blood test, that is a serum AMH, the anti-Mullerian hormone, to detect the ovarian response.
Yeah. And what do you do? I mean, we are in a rural population, we are in a semi-urban and semi-rural population in MP, because MP is not a very highly developed state. So what we do is our patients, whoever comes to us, for 20 years, they will remain at the age of 30. And for 20 years, they will remain at the age of 40. They never grow. So what is one thing which will tell you now with Narendra Modi and his innovations in the government, what is one thing which has really helped us in determining the correct age of the patient?
I think the Aadhaar link which he is doing with the PAN, so
Yes.
those two link up is helping us a lot.
So don't you think that Aadhaar is a blessing? Because in that
Absolutely, it is.
Aadhaar, you can come to know the name of the wife, the name of the husband, plus the exact age of the patient. So, and the new software of the machine is also very smart, like the ultrasound machines nowadays. It is highly advisable when you fill in the patient data, you fill in the date of birth also. So these
Yes.
machines are very smart. They will save the data. So every time you fill in the name of the patient, the date of birth will also flash. Right. So AMH and AFC definitely are yes, and it's a big no for doing FSH. It is a big no for doing basal estradiol, and but you can do BMI easily in the BMI. If you do the BMI in your OPD, which is a very simple calculation, you can at least give a positive motivation to your patient to reduce weight. If in case, she's overweight, though nowadays the guidelines are that weight should not be a deterrent to your starting ART, but still I feel if that patient can come in the normal range of BMI below 25, 26, she will definitely have a better stimulation and a better pregnancy. So
That's a very appropriate message, ma'am. Actually, we are seeing several reports where FSH, LH, E2, inhibin are still being prescribed, and we actually don't need these tests, these expensive tests to categorize or know the response or predict any response.
Yes, definitely. That is the message. That is the aim of any webinar or panel, that you should have some carry home messages which can change your practice. So, okay. So this, we've already said why AMH and AFC, which is important. Next slide, please. I just underlined that AFC is a variable parameter because it is affected by various background conditions like timing of the cycle, prior use of OC, but very useful test. But if out of these two, which is more stable, it is the AMH because it is early, reliable, direct indicator of ovarian reserve decline. Next slide. So who is the next panelist? Dr. Shashmita, no, Dr. Madhumita. Dr. Madhumita, madam, please define an antral follicle for us. How do you define an antral follicle, madam?
The follicles that are present in the beginning of the cycle, say in day 1, day 2, and they measure around 5 to 7 millimeter, and they're very responsive to the hormonal stimulation, gonadotropin stimulation.
Next slide. Yeah. As soon as the panelists start speaking, Purnima, you are supposed to show the answer also, because then we will proceed faster. Madhumita, madam, you are absolutely right. The best form of assessing the AFC is on day 2 or day 3 of the cycle, because this is the basal phase of the cycle. This is a radiology paper. So these follicles are actually 2 to 9 mm in size. They should be well-defined, anechoic, with smooth margins, no internal septations or nodularity. And the main thing is you have to count in both the ovaries. Often in clinical practice, what we do is right ovary AFC is this, left ovary is AFC is this. So actually that is, we speak like this, but antral follicle count is basically the sum of antral follicles on both the ovaries. So you can measure on any day of the cycle and you are very happy with AFC. Madhumita madam, this patient is Poseidon 3. She is expected poor responder below the age of 35. So would you like to give any of these adjuvants you like?
Yes, I would like to give an adjuvant to help her because anyway she is going to be a poor responder. So I would like to give DHEA, which is commonly available, 25 milligram TDS for 4 to 6 months. The others also can be given like testosterone and growth hormone and all. But I think DHEA is commonly available and easy to use.
Madam, I think DHEA is 75 milligram OD.
Yeah. Okay.
75 milligram capsule. 25 milligram TDS is sildenafil, which we give vaginal. Sometimes we have to give, if we want to give for thin endometrium, because DHEA is a single capsule. So many companies have brought it out. In fact, we presented a paper in ESHRE on DHEA, but nowadays there is so much of criticism of androgens. We are using it according to our basic knowledge and our practice and our good results. So, Madam Madhumita ma'am, can you tell us, or I would rather start asking this question from Dr. Singh. Dr. Singh, what according to you is the best? You have read so many papers, you read so many journals, Fertility, Sterility, ESHRE, Jogi. What according to you is the best form of evidence which you will inculcate in your practice totally, very fast? Next slide.
Actually, we will go for randomized control trials or meta-analysis. Basically, I follow the Cochrane database.
Okay. You follow the Cochrane. Cochrane. And Dr. Rohini, can you tell us that after these meta-analysis, and Dr. Rohini, is she there?
Yes, ma'am. Hello.
Sorry, Rohini,
Hello.
this is your question. So now you have to describe this very complicated diagram, which I got by chance yesterday night at, I think, very late at night, I got this diagram. But this diagram is meant to show you that there is 5S in clinical evidence, studies, synthesis, synopsis, summaries, and system. So your meta-analysis is just at step 2 of this huge pyramid. So can you tell me something about this? You seem to be very young, so you must be knowing this from your PG days.
Thank you, ma'am. Ma'am, whenever we decide about any treatment, we first see what are our levels of, what do we practice. Then we search for the various studies. The studies are the ground level of evidences when we compare amongst all. And then we see what are the group of studies which are published in various journals. And then after that, we search for some good synopsis. And finally, and these synthesis and synopsis, they form the maximum amount, like the meta-analysis, the RCTs, they all come under these categories. But the most important are the evidence-based guidelines, which are formed by the ASRM, ESHRE, and it is published in various books, the practice guidelines, and above all, as per this pyramid, the system, the computer generated,
becomes a system. Then finally you reach the system. So this is
the system is the final, the verdict, what we should practice.
Yes. Thank you so much. Next slide, Purnima. So androgens and all we have already discussed. Now, can anybody out of all the panelists can tell me androgens, how they act? We also know that. Shashmita, Dr. Shashmita is there?
Yes, madam.
Shashmita, can you tell us what is the latest consensus about androgen treatment as discussed in ESHRE, or something about T-transport trial, if you know?
Madam, there are two schools of thoughts. Some studies are telling in favor of androgen, and that is used from the previous cycles from day 7 till day 1 of the next cycle. And there are also certain studies who are against it, like they tell it is just like placebo. But in our experience, in my personal experience, just I get a good result out of androgen use.
So do you use the testosterone gel or you're using DHE?
No, madam, I never used DHA actually. I prefer using testosterone gel.
Are to be applied on the skin, right? So this is just for your information that I would like to see the T transport trial, Purnima. Yeah. This this people who attended ESHRE this year, there was a huge lecture by Nicholas Polizos, and this was packed hall because Nicholas Polizos had given us the findings of the T transport study. Here, transdermal testosterone was used for a long time, about 50 to 70 days before ovarian stimulation, and this multicentric RCT found similar outcome from ovarian stimulation in patients at risk of poor response, irrespective of their prior exposure to transdermal testosterone. So testosterone was given for several weeks before ovarian stimulation. This was a whole multicentric study in Europe, in many centers, in many reputed centers. Dr. Polizos, we know he is a great researcher and scientist, and he categorically said that there was no difference. So I don't know whether T transport will carry on or they will, form ring a death knell for testosterone. So next slide, Purnima. What about your experience with growth hormone, Dr. Shakti? Is she there?
Ma'am, sir is not joined, I think.
So Dr. Shakti Tripathi is not there. Anybody can take this question who is using growth hormone. Anybody who has experience with growth hormone in practice, I don't have much experience except for the fact that 1 or 2 patients have come to me from metro cities during the stimulation protocol that, madam, you please give us the injections along with growth hormone. So I used to give them, the gonadotropin plus a growth hormone daily and or alternate day. And then they used to go for pickup. But I personally have not used much of growth hormone.
Madam, just I would like to share our experience. In 2017-18, when I started this journey, then in case of a previous poor responder or elderly age female more than 40 years, I started adding growth hormone. But just I saw the cost is very high. Along with that, practically no difference between using it and not using group. Then literally I have not used since 2019 till now.
So it is basically your individual choice, and the message is now we have to, in poor responders, we also have to cut down the cost of the cycle. So better not go for empirical therapies, go for therapies which are evidence-based or in the therapies which you trust. So next slide, Purnima. I think we can just wind up. Antioxidants, definitely, if somebody can put in a word about antioxidants, because this is one adjuvant which we can use for males as well as females. So can anybody highlight use of antioxidants, Dr. Lipsa or Dr. Singh, Dr.
Yeah, antioxidant can be used because it can activate the mitochondrial system, and when the reserve is low, so it can give good oocyte quality also. So we can use antioxidant prior 2 months prior to stimulation.
And I feel, pre-treatment with antioxidants is very safe treatment. It is not that
it doesn't have any side effect also.
And even if it doesn't help in IVF in general, it will be good for your body. You are exposed to so many carcinogens. You are eating all the synthetic chemicals in your vegetables, fruits, everything. Even in your eggs are infected with chemicals. So some antioxidants are good for your body. It will not do any harm. So adjuvant treatment is yes. And at the end of the panel, we have come to antioxidants, yes, DHA, DHEA plus minus, androgen gel plus minus, growth hormone, no. Okay. So I don't think we will stimulation protocol. We are not covering in this panel, are we, Purnima?
Yes, ma'am, only this line that.
Okay. Can somebody tell me for Poseidon 3, Dr. Singh or Dr. Lipsa, whoever wants, which sort of stimulation protocol will you prefer for this particular 34-year-old patient with AMH1? Agonist or antagonist?
Ma'am, antagonist protocol.
Okay, so that is also, everybody wants antagonist. So we are very happy with antagonist. All of us, we are very happy with antagonist. Okay. So any difference you want to give, any message you want to give for your viewers? Dr. Singh, that there is a lyophilized antagonist and nowadays there is a pen loaded antagonist and the cost is different. the cost is different by nearly 700-800 rupees. Is it? So would you like to, is there any difference when you have a preloaded antagonist in a pen or you have an antagonist lyophilized vial?
I have not used any pen. I don't have any idea.
Okay, because this time, this time.
But definitely I will go for synchronization and pre-stimulation synchronization down regulation by using a OCPIL or a Estradiol in these patients.
So, sir, are you still using OCPIL?
Yeah, I am using for 12 to 14 days, and it doesn't have any. I have used so many years, and it does not give any bad result. And there is a study also we have done, with Dr. Gutbutia sir, Nova IVF, and we have shown that it does not affect the oocyte quality, live birth rate, other things also. But it should be limited to 12 to 15 days only, not more than that.
Please share the protocol of using OC for 12 to 14 days.
There is a paper on that. I already, I'll give.
No, don't give. You have to tell now. Please tell us. Please tell us which day of cycle you start your OC and which cycle.
We can start 12 to 15 days prior to stimulation.
Okay.
When we get once it is stopped, then we have to give a 5 days pill-free period. Pill-free period, 5 days. Then on the 6th day, whether she is having period or not, we can start stimulation.
Yeah. So you basically pre-treatment, everybody is using post-ovulation in the latter half of the cycle. Yeah. Nowadays, you're not giving OC right from day 5 of the cycle for 21 days. You're not doing that.
No.
This is the advantage of synchronization. Next slide. We definitely do not vary the days of the dose of gonadotropin, and adjustment in the mid-cycle is not acceptable nowadays. Okay, so we are a little short of time. We'll move to case 2. And I think Dr. Lipika is there or not?
Is not joining, ma'am.
Okay, so you can move to case 2. Purnima is going to take the next case.
Thank you, ma'am. So next case is a 32-year-old woman with normal ovarian reserve with normal HSA, underwent IVF for unexplained infertility of 3 years, BMI 28 kg per meter square, and her AFC is 6 to 8, AMH is 1.4. It is the detail of the IVF cycle which was done. She was stimulated with injection HMG, and total 5 oocytes were retrieved. Total M2 were 4. And total embryos, 2 grade 1 and 1 grade 3 embryos were formed. So my next question to Dr. Madhumita ma'am. Ma'am, which Poseidon group does she belong to, this patient?
So this patient is less than 35 and has a good ovarian reserve. So it should be group 1. And since the retrieved oocytes are 5, so it should be 1B, right?
Yes, right, ma'am. So this patient belongs to group 1B. Next question to Dr. Rohini ma'am. What will be your choice of gonadotropin in this patient in the first cycle itself?
Yeah, I will choose with recombinant FSH since she is young, and recombinant FSH has a better response than the HMG. Like I think HMG was used in this cycle.
Can you tell the difference, like HMG, the type of HMG and the type of FSH which are available in the market right now? The type of gonadotropin, basically.
Basically, we have recombinant one, we have highly purified one, and the urinary, I don't think we are using anymore it. And out of all these 3, obviously the recombinant one, they are the most purified one. So the response is usually good. The highly purified one are these the HMG, and HMG is a combination basically of FSH and LH. So for young patients like this, she is like 32 years. So recombinant FSH in the initial phase of the stimulation works, I think, better.
Yes, ma'am. So these are the different kind of gonadotropins, like first urinary gonadotropin, which we hardly use nowadays, HMG, highly purified HMG, purified FSH, highly purified FSH, HCG, highly purified HCG, and then recombinant gonadotropin, recombinant FSH, HCG, Ovitril, and LH. As we all know that the advantage of recombinant FSH is that it can be produced in large volume without variability in composition, and it has overcoming the problem of finite donor, and there's the introduction of pen injection device for subcutaneous injection, and as ma'am rightly said, that it is very good in consistency. It gives consistent result, recombinant FSH, and we are very confident enough in using it. So my question is that even though we all feel that recombinant FSH is very good, but this is the study. There are very few studies in the poor responders which actually has compared the menopausal gonadotropin and recombinant FSH. And this is the randomized control trial which I've given the reference, and it says that there is no difference. There is no statistically significant difference. Until date, this is the only randomized control trial in poor ovarian responders comparing HMG and recombinant FSH. So I think that is up to the practical experience, what we are comfortable with, and with which gonadotropin we are getting a good result.
I think Purnima, you will go to the questions now.
Yes, and the next question is, Dr. Sasmita ma'am, does anyone have any experience of Corey-Polytropin alpha for such patients? Has anyone, Dr. Sasmita ma'am, have you ever used it, Corey-Polytropin alpha?
No.
No, this is not available. This is not available. This was
Not
available for some time in some European countries. And I have read studies about this Corey-Polytropin alpha. So this was made by Merck. And the purpose was you give one injection of rec-FSH of Corey-Polytropin alpha, and the action lasts for 6 to 7 days. And the evidence says that once you use Corey-Polytropin alpha, and in the other patient you use rec-FSH for 6 days, you will get more number of oocytes and more coherent cohort of follicles with Corey-Polytropin alpha, because it is there in your body and it is being released in a sustained way.
Yes.
Continue.
So next question, Dr. Shakti sir is not there. Anyone can take this question. What should be the dose of gonadotropin in such patients?
Can start with 300, I think.
My main concern is, should we increase the dose beyond 300 for poor responders, sir?
No.
Yes.
It should not be beyond 300.
Yes, beyond, because as already Dr. Manish Bankar sir explained that these patients have fewer recruitable follicles, and that gonadotropin, independently of the doses administered, only support the cohort of follicles sensitive to stimulation without generating follicles de novo. So up to 300 is good enough. So my next question, Dr. Arun Singh sir, what can be the cause of hyporesponse in such patients? Because she responded poorly.
There are many causes, but most common cause will be polymorphism. Genetic causes will be most common one, but other causes like low starting dose of gonadotropin may be there, or there might be trigger factor, or there might be oocyte pickup factor. All these factors are there. But most common in these cases, if the standard regimen has been used, then most probably it is a case of polymorphism.
Yes, definitely. Rightly said, sir. Single nucleotide polymorphism is the most common cause if we have given everything adequately. Dr. Lipsa ma'am, should we screen all patients undergoing IVF with adequate ovarian reserve for SNP in this era of advanced genetics?
No, actually till now, I think no studies suggest so that we should be doing it routinely. But of course, for patients who have had a poor ovarian response previously, and if the economic state and the facilities are available, then we should definitely offer the patients at least.
Yes, very rightly said, ma'am, because this is not a good cost-effective option to offer this screening to all patients. Dr. Lipika ma'am is not there. Anyone can take this question. How many embryos will you transfer in such patients? Only 5 oocytes retrieved, 2 grade 1 embryos.
So in this particular case, if it is it a day 3? 2
Yes,
grade 1?
Day 3, ma'am.
It's a day 3. So if it's a day 3, yes, after counseling, we should transfer both the embryos. We can transfer both 2 grade 1 embryos, day 3. That is at least increase the chance of pregnancy. But considering the risks of multiple pregnancies as well, it is again an option. An offer should be made. There should be a counseling that yes, if we can consider multiple cycles and a chance of having negative results with single embryo, and the patient is fine, we can go for a single embryo day 3 transfer as well. But yes, if again economic factors and social background, if you consider, then both grade 1 embryos of the day 3 should be transferred.
Yes, thank you, ma'am. Actually, evidence says that one embryo only, but if we are very desperate to give her good positive result, we can, I think practically we all go for the 2 embryo transfer, but we have to explain the risk of multiple pregnancy.
There should be a counseling and there should be a documentation that we have at least explained the risks involved.
Yes. Dr. Madhumita ma'am, would you increase the dose of gonadotropin in next cycle for this patient?
Usually the response is, I think, best with the 300. So maybe increasing the gonadotropin dose wouldn't help, but changing the gonadotropins and trigger and taking care of the lab and the embryo would be a better option than increasing the dose, the starting dose of gonadotropin.
Yes, ma'am. But ma'am, since she was a normal responder, according to the good ovarian, she had good ovarian reserve. So ideally, we would have gone up to the 150 to 200 IU of gonadotropin. And we, if we see that with 150 to 200, she's not giving good response, in the next cycle, we can definitely increase the dose by 25 international unit. And this is the study which actually has proved it, that if you increase the dose by 25, you can get good oocyte yield.
Yeah, so if you're using less than 300, yes, you can definitely increase.
Yes, ma'am. So this is in short the group 1 management, which we have already discussed. Over to Dr. Monica ma'am for case 3. Ma'am, you're muted.
The main difference in case 3 is that it is Poseidon 2. So she is unexpected poor responder of older age group. Now here we find that she comes with the history of 1 failed IVF and her AMH is 1.3, AFC is 6. Now in this IVF cycle, she was only given recombinant FSH and an agonist long protocol. 3 M2 were retrieved, ICSI was done, 3 embryos were grade 2 on day 3. And all 3 embryos were transferred on day 3, considering her age. By that center, still the beta HCG came negative. So she has come to you for a repeat IVF cycle after 1 or 2 months. So can Dr. Singh take this question or Dr. Lipsa, or either of the two? How do you plan the next IVF cycle in your center? She is previous 1 IVF cycle negative.
Yes. So, madam, since she's an elderly, like above 35, we know there are changes in the oocyte. So we can counsel her that since various protocols are there in IVF, we can go for addition of LH or HMG in the next cycle and have a better cohort of follicles. And that would definitely increase the response, and so that more number of follicles can be retrieved. Also, considering 6 from 6 oocytes, so few have been retrieved, an option of embryo pooling may be also given to her if such a scenario is to be repeated, comes again.
So what is your choice of recombinant? What is your choice of introducing LH in your patients?
So, ma'am, in the setup we work, I think I routinely use HMG because recombinant LH is pretty expensive, so it doesn't come up to the cost. So we routinely use HMG.
Recombinant LH, hardly any centers are using recombinant LH. So I was, talking to a top IVF specialist from Mumbai, and he was very convinced with recombinant LH, but now I talk to him again after 10 years, he is not using. So has anybody got experience with Menopure? Because I was in many conferences where they are saying the LH activity of Menopure is different from the LH activity of urinary HMGs. Can anybody throw some light who are using Menopure? Any experience with Menopure from Ferring?
We have used Menopure, but from urinary point, we don't have much experience. We get good results with Menopure.
Yes. So Menopure, actually this study was not comparing Menopure with other HMGs, but what I gathered when I talked to many colleagues from Maharashtra who are using Menopure consistently and they don't want to change to any other urinary HMG. You know, Menopure is also urinary HMG. But here in Menopure, the activity of LH is HCG derived. It is HCG derived LH activity which gives it its consistency. I talked to many Ferring pharma people also. I went through many literature also. That is why they vouch for the consistency of action of Menopure. Nonetheless, according to this paper, the mean number of mature oocytes which were retrieved when you gave recombinant FSH and LH separately, this was much higher as compared to when you gave HMG. But since none of us are using recombinant FSH and LH, separate injections, we will not be able to comment on this. Next, Purnima. FORT and FOI we have already discussed. And embryo pooling also, duostim also. I think we can skip duostim also. ART calculator has anybody used? It has been given by the Poseidon group and it is available on the net. Does anybody use an ART calculator in Indian scenario? Let's go to the ART calculator slide. So ART calculator uses very simple things. It is like something like we do fetal medicine. We try to take out the, the probabilities of aneuploidies through a computer. Similarly, an ART calculator has been given to us by Poseidon group. You simply put the age of the female, the source of the sperm, and what success probability you are looking for. Suppose you're looking for a success probability of 80%. Then this 37-year-old lady will have to collect 11 mature oocytes in order to get one euploid blastocyst. So this ART calculator is basically a guideline for you to how much initial dose of gonadotropin you should start. So people who are interested can be, this thing. So if you get a poor quality embryos, next slide, Purnima. Should you still transfer, Dr. Singh? Should we transfer poor quality embryos? Or do you feel
I will definitely discuss the chances of the pregnancy chances. Then only we'll decide. But I will prefer not to transfer.
Okay, because they have a low implantation potential. But once they implant, they will give live birth rate as good as the fair embryos. So mainly you are worried about the implantation. So just now I was talking about to Purnima about my one triplet I have had after many years. And that was because I transferred 2 grade 1 embryo and 1 totally useless looking embryo. Because I thought, what will I do? And that patient had come through a government grant. So she was not paying. The government was paying something for her little bit. So I thought, what will I do with this remaining embryo? I transferred that also. And she is now 14 weeks with perfectly alive and kicking triplets. So we really, now she doesn't have money to undergo fetal reduction. I have referred her to our medical college for Shirodkar circlage. So this is it. Next slide. This is this thing. Now, last case is very interesting case because here you have an AMH of 0.1, or let us make it, she has an AMH of 0.01. She has small ovaries on ultrasound. She is 45-year-old and she is for ART. Okay. So how do you deal with this? Anybody can take this question now. And Dr. Singh is there with us. Dr. Randhir Singh is also there with us, who is the ART law expert. He will be taking questions from you.
I think with low AMH, as we have seen that if the low AMH with the Poseidon group, the lower age, we have seen Dr. Monica, a young gynecologist, she has got a AMH around between 0.6, 0.8, and still we have got 4-5 embryos. So after trial, because sometimes you have to see the age, AFC and AMH, but suppose you have decided that in spite of the failed stimulation, she is not able to get the oocyte of her own genetics, because every mother wants that they should have their own at least one trial. So one ethical trial, scientific trial, if she fails, she is going for an egg donation. So you have to do the formalities of all egg donation. So better if I'll go that, suppose a patient comes to you, because for everything, because MP was the first state to get a surrogate board and we processed the first surrogate 3 months back. So what I'm saying, if anybody needs a oocyte donor, just don't write AMH 0.6 or 0.8. You should have a certificate of authenticity, because if Dr. X has advised oocyte donation, please be that in future you might be asked in the court to prove yourself. So how will you prove? Best is a failed stimulated cycle of her own egg, either you or your previous history. So you have to, the patient comes to a clinic, a gynecologist, because nowadays we have got 3 ART laws, ART1 only IUI, ART2 only IVF and ICSI and all, ART surrogacy. The surrogacy is but natural, has to be ART2 level. So we have got 3 type of registration, one ART1, ART2 and surrogacy. So
Dr. Randhir Singh, you mean to say that 0.01 AMH and that patient is taking permission for oocyte donation. So we have to do one cycle at 0.01 AMH for her. And
So
if-
that cannot
Dr.
afford
Monica,
also.
Dr. Monica, you have to prove
How
yourself
many
in the
poor
court.
patients?
Only the one value of AMH will not get your certificate. You have to prove by your documentation, AFC 0, other things, that is AMH is 0, irregular cycles. No, it's basically like menopausal. So you have to prove yourself. If you have proven the best, what I say, if you can prove that there is no need of a stimulation cycle for a low AMH. I'm not going for a value. It you have to prove. So either you take a certificate. Better in this field is that along with you take one more certificate of your ART consultant, so you are always safe. Because if I have got an AMH of suppose 1 and I don't want a oocyte of my own, I might demand you, like the patient demands, likely please do LSCS, don't go labor trial. But in the court of law, you will face, because that cannot be ground. So my thing is that to make a safe, a gynecologist, the patient needs egg donation, make your certificate, your documentation proper. So like
can
MTT,
you ask, Dr. Randhir, can you ask some questions about this case from our panelists?
yeah. So what I'm telling you is that straightforward, the patient is coming with a low AMH. So what is your, anybody can take, what is your view? How will you deal with that?
The AMH,
without any stimulated cycle. The patient has come, you have done just AFC, sonography and AMH value. Now, how you will proceed? Directly you will advise egg donation and then how you do it?
Sir, age is a biological clock. So without seeing the AMH and AFC also, by seeing the age group and along with our clinical parameters, there is no doubt that we have to go for a oocyte donation program. And with the recent ART-No guideline, we have to do the insurance and affidavit kind of thing. Along with that, we have to recruit the donor from the ART bank after proper screening of the sexually transmitted disease and ruling out other diseases. And in that case, and for this particular case, it is a suitable candidate for oocyte donor program.
No. My straightforward question is that the patient comes to you, your clinic, that मैडम ये मेरी रिपोर्ट है, अब मुझे बच्चा चाहिए, मैं चाहता है कि मेरी खुद के ही जीन से बच्चा हो सके. What you advise?
Sir, this is a case of 6 months of amenorrhea. So looking at the size of the ovary, everything, we have to tell the prognosis of stimulation. Okay, so just we cannot tell ki haan donor hi chahiye aapko. We have to tell the pros and cons of the outcome of the stimulation. And even if there is no AFC anything and the patient insists, definitely we have to give a dose trial, giving 5-6 doses, and whether what is the outcome of the follicles, all that.
Especially if the patient is not above 38 or 40, the patient is 33, 34, 35, around that. At least you can give a trial, no? And saying that, yes, saying that hardly 1 or 2% chances are there you will get a oocyte of after spending 50,000 or something gonadotropin cost, because you are going to give a minimum 300 gonadotropin for 4-5 days.
Even with one follicle also, we should give a trial for a biological.
So I think if the patient comes and says my genes are important, you will give a trial looking your knowledge. Then what is I think I just brief is that you have told in initial things, but now all this part, getting a donor is a part of ART bank. So now I'm considering that your ART center doesn't have the ART bank. So I think what the law says is that just you have to give a prescription, give a certificate to a patient that you need a donor cycle and you can contact ART bank. I'll prefer that as a legal, I will ask and guide everybody, please don't write any ART bank's name and address. Just write, you need an egg donation. Please go to ART bank and come with the documents. So now the patient with referring to document, this document will go to ART bank. ART bank will just see a certificate by a doctor that she needs an egg donor. It is a job of that ART bank to screen themselves, because this patient also needs. So they might want to match the group, blood group, anything all. So this patient also should, because why I'm saying, this patient also should have all the infections. Suppose the ART bank has not done the HIV and they supplied oocyte bank. The donor was HIV negative. But later on, if the conceived mother gets HIV, they may sue you, knew that. So to be safer, let the ART bank do whatever the investigation you have done. If they want, they can repeat, because all the payment is going to be done by the commissioning couple. So according to your one certificate that patient needs donor, they will start doing the recruitment of donor and all. We as a clinic should not be involved who is going to be donor. Then that patient, with the help of ART bank, will get all the paper with the support of what the ART says. If the patient comes to you, what paper you will see is that donors detail, donors insurance, and being a physician, you should see all the investigations also, like infectious disease and all. If the patient demands, now the patient came yesterday, today the patient has some recessive homozygous, 3 abortions, both. So some homocystinuria. The patient asked me, Dr. Saab, will you take the guarantee of that the donor oocyte my 4th baby will not be homocystinuria? Then I have to get all the DNAs done. Routine in ART Act they have not done. One DNA couple will cost you around 50,000 minimum to you. Your cost, complete DNA and all. So instead of all complete DNA, both husband, wife, then also nobody can sure 100% of a normal child. So that part you should get it. So all those papers, when they come, you have seen it, now insurance is there, everything is there. Then now you can stimulate and do the donation. Any other person, panelist can have any doubts they can ask?
So can the panelists tell me at what AMH, suppose you're seeing AFC of 1 to 2 and AMH is 0.1, would you stimulate this patient? 0.1 AMH and AFC 1 to 2, because my experience I'll tell later. But what is the limit? Would you stimulate a patient with AMH 0.1 and AFC only 1 or 2?
Yes, madam, with the advantage, if the female is more than 35 years, then with the introduction of and availability of the NICS and other genetic testing, we can rule out aneuploidy. So even with the advantage, even with one follicle also, then it is not unusual we have got a good result. One egg stimulation, then one oocyte is retrieved, that is M2, one embryo form transferred and single healthy baby. So definitely, and if it is less than 35 years, the prognosis is very good, as most of us would have experienced. If more than 35, suppose
this patient is more than 40 or more than 38, will you get the same result with AFC 1 to 2?
The result expectation will be less, but again, if embryo are formed with ruling out aneuploidy, so we can expect a good implantation rate, even if the age is more than 40 years.
I'll share 2 cases with you where I stimulated with 1 AFC and one with 2 AFC. One was a doctor, the second was a general patient. In one of them, I got a sort of a solid follicle. I could not aspirate. Despite giving antagonists, despite being very careful, just hours before I did the pickup, the whole follicle became echogenic, hemorrhaged. And naturally, we could not, retrieve the oocyte. We had to explain. And the second patient was also, we had 2 follicles. Even the E2 rose, though E2 rose less, E2 should definitely rise 250 to 300 for every mature follicle. In that case, the E2 rise was just 150 or so. And here also, Dr. Randhir and I, we did the case and we got empty follicles. So sometimes this estradiol E2 is produced by the granulosa cells without any oocyte. So these are the 2 experiences I have. So now whenever I see AFC of only 1 or 2, and I see age more than 37, 38 or 40, even if the AMH is 0.1 or 0.2, I'm scared to stimulate because that patient can lose that much of money. unless the patient is very rich and can afford.
But I'll tell you, Dr. Monica, you have to be very, you should be able to go into the brain of the patient, what patient wants. If patient says, I have not done even a single cycle, and Dr. Monica, you're saying that my age is 38, in the sonography, it is showing 1 or 2 follicle, why not going for stimulation? So it's better always take a consent that I advised that chances of getting a oocyte normal and pregnancy is hardly less than 5%. Still the patient goes, so at least giving 1 lakh gonadotropin and all, the patient will not sue in the court. That should be taken in mind to everybody.
Very important, you should know the population of patient coming to you, whom to stimulate, how much money you can waste for the patient, and definitely when you want to stop that stimulation. So I think any other inputs from our panelists, any other interesting case you would like to share? Any problem you're having with oocyte donation in your state?
Yes, actually, after hearing Dr. Sunita ma'am, for patients who are highly desperate for having their own biological child, this stem cell rejuvenation therapy or any kind of ovarian rejuvenation therapy might be offered if the patient seems to be affording, because we can also give them the statistics like, the affording or the aware patients are very much fascinated by numbers. Like people above 40, we need around 15 to 20 oocytes to get 1 euploid blast. So that is the range of, or the ratio of how much success we can get by stimulating elderly patients. But yes, we had a patient who was very much like desperate, like no matter what, we don't want to go with donor eggs. We need to have a trial with self. And strangely, there were only 2 follicles and AMH was 0.2. And she has undergone twice stimulation. And since being very aware patient, she wanted a blastocyst, culture only. And both the times she had blastocysts only. It's very strange that we get grade A embryos blastocyst. And previously also she had undergone stimulation elsewhere, and there was she was failed IVF twice. And then we had offered her PGTA, let's do a PGTA, and both the embryos were aneuploid. But then again, she wants a fourth stimulation as well. Then no, we won't do a aneuploidy testing. We'll again go for directly a transfer. So such rigid patients, documentation is very much necessary. Like sir said, that we need to make them aware that what are the chances of pregnancy and how long do you want to continue this.
Yes. And
actually, Dr. Mishra, one thing is there. See, if a patient is coming at 38, because now ART Act has said that up to 55 male, 50-year female. So they know option, एक donation का तो मेरे पास अभी 5 साल बाद भी है. See, that you should keep in the psychology. Only the part comes the money. So whatever is there, and just अभी 10 seconds पहले मुझे याद आया, Dr. Mishra, now giving to in counseling consent also I'll write. There are new techniques like stem cells, which are costly. I have informed you, and you have told that, no, Dr. Saab, I'm not going for a new technique. I'm going for egg donation. That now comes in. So you can write all new interventions, stem cells and all have come that might give the chances of your own baby, but the success rate is very low.
Right.
Yeah, this should come into consent.
Yes, I think risk of aneuploidy post 40 years should be in the consent, I think. Means that is also very important.
Actually, that is there always, because aneuploidy you can get even at a 30-year also. So that is not a must, because we should make a broad consent, because we, therefore मैंने क्या कहा, if the patient own oocytes are there, आपको court case नहीं करेंगे. If you ever take a donor, they want 100% pure till death, 100 years तक baby को कुछ ना हो. Who can guarantee? No. That should come in the party.
So that brings us to the end of this panel. I thank all panelists for a wonderful interaction. If there are any other doubts, we have our ART expert with us. You can ask. And we really thank ISAR office bearers, and thank all of you for being so interactive and such a wonderful panel. And the last slide is, of course, Purnima, can you show the last slide?
This is the last slide.
No, one more slide is there. No, one more slide after this.
Oh, yes.
Please extend your blessings for our convener. The convener of ISAR Perfection Series is Dr. Sunita Tendulwadkar. And because of her, we could do this wonderful program, and because of Nandita Palshetkar, madam. So in your state, it would be a very big help if Odisha chapter ISAR could support Madam with Foxy boards. Thank you so much.
And one in the end, I will share you that Dr. Naita Parshetkar ma'am, our president, she's always with us to help every of us. Recently, last month, we have gone to the National ART board, the minister and all, and we got the amendment of ART Act where our MS surgeon who are doing better tests and everything than the MCH Euro people, they were out of the practice. आप खुद सोचिए 25 साल से जो सर्जन मेरे यहाँ माइक्रो टेस्ट से सब कुछ कर रहा है, sudden with the act he's out, and young boy MCH he doesn't know how to open the testis. So what I'm saying, so we are thankful to Naita ma'am. She got with her efforts at the change of National ART that now MS surgeon who has got the experience who are doing now legally they have come. So any problem with the ART Act, see, in the democracy that is there, if you fight for the good thing, you will win. So any problem with the ART Act, you think it's not, because yesterday in the group was saying that the mother wanted the oocyte of a daughter with the father for a second child. So it's totally unethical because in the ART Act, they have not said anything. A donor can be anybody, a relative or anybody. So ethics also should come. So what I'm saying, if anybody of us forward this message to all ISAR members or gynae practitioners, if they have any problem, our ISAR president is always with us. Foxy president are always with us. We'll meet directly with the health minister, PMO office, and we'll get it amended. Thank you.
Thank you, everyone.
Thank you, ma'am.
Thank you, ma'am, for nice discussion. Thanks a lot. Ma'am, you are muted, ma'am.
So we have learned so many things from all of you. Besides studying and preparing for the panel, we have learned so many things from our brilliant speakers, and Dr. Monu Patnaik has been there right from the beginning. I really appreciate, sir. You have been there and listening to all of us. It was a long webinar, but I think we have practically covered everything about poor responders. Haven't we, Dr. Lipsa, Dr. Singh? What do you think? There is nothing remaining, even stem cells, everything. So I think we are, perfectly prepared to tackle any poor responder. It just now we have to develop our clinical skills, judgment, assess our patient, assess our environment, which state we are living, what are the legal regulation, how much our patient is affording, and so many things.
And the most important part, ma'am, are documentation. I think with the new ART law, this documentation part needs to improve so that we can be saved in the court of law if anything goes wrong.
And I sincerely feel this ART law in the long run will help us only.
Right.
Things were so unregulated all over the country that ART law will bring some sanity, bring some ethics into our working. We were having a lot of black sheep in the family. So I think that will be corrected.
Absolutely.
Thank you so much. Thank you.
Thank you, ma'am.
Thank you. Because both of you have done marvelous job and excellent. I'm very happy to lucky with you all.
Thank you so much.
Thank
sir.
you so much. Sir.
Thank you, Dr. Vishal. Thank you, Ronak from technical support. Thank you, Team Intas, for always supporting us. And here's looking to another dynamic webinar, another great webinar in the month of August. Thank you. The topic will be announced soon. And whoever wants to take part in that webinar, please, you can message me or Purnima directly. Thank you. Thank you so much. Thank you. Thank you, Dr. Vishal.
Thank you, madam.
Bye. Bye.
Bye.